Hello, good morning, everyone, and it's a pleasure to welcome you all for the day third for the ball rolling with his welcome and introduction.
Driver mutated disease, and especially had fantastic discussion on what to be given post uh, development or resistance in driver mutated disease. So today's day we focused on locally advanced lung cancer followed by immunotherapy in its various role in EA. So without wasting time, let me call on Dr. Nandini Menon, who will be the session coordinator for this session and will be carrying on the proceedings further.
Good morning, everyone. I welcome you to the first session of today. I would like to invite our chairpersons, Dr. Rakesh Taran from Indore and Dr. V. Kannan from Mumbai, to start the proceedings. And also, I would also like to invite the first speaker, Dr. Nikhil Kalyani from Mumbai, for his review of the first abstract.
Ram Ram, thanks. I think now Dr. Nikhil Kalyani may start his discussion now.
Thank you, sir. Good morning, everybody. Today I will be presenting a paper titled Addition of Metformin to Concurrent Chemoradiation in the patients with locally advanced non-small cell lung cancers. The results of a phase 2 randomized trial, NRG LU001. This was published in JAMA Oncology by Skinner et al. So, chemoradiotherapy is a standard of care for stage 3A and stage 3 lung cancer. Recently, a Pacific trial has been published, which says that maintenance durvalumab can be a new standard of care. Coming to the metformin, which was an investigating agent here, it has an anti-neoplastic effects. It has a good safety profile and it's very low cost. 001 trial was started prior to the results of Pacific trial. The aim of our study was to check whether addition of a metformin improves the outcome in non-diabetic unresectable stage 3 non-small cell lung cancer with chemoradiation. It was an open label randomized phase 2 trial, was carried out between August 2014 to December 2016. They included all the patients with stage 3A and stage 3 non-small cell lung cancer, both adenocarcinoma and squamous carcinomas. All the patients were non-diabetic and they were planned for definitive CTR. Treatment arm consisted of radical radiotherapy to the cross disease and the involved mediastinal nodes to the dose of 60 gray 30 fraction over a period of 6 weeks, either with a 3D CRT or an IMRT. A chemotherapy schedule consisted of a weekly paclitaxel and carboplatin concurrent with radiotherapy, followed by 2 cycles of 3 weekly paclitaxel and carboplatin as a adjuvant chemotherapy. Two arm consisted of with or without metformin during the concurrent and adjuvant chemotherapy phase. A dose of metformin was planned for a 2000 milligram per day in 3 divided doses of 500 milligram, 1000 milligram, and 500 milligram, 3 times a day. The primary endpoint of the study was progression-free survival, and the secondary endpoint consisted of overall survival, local regional control, and the toxicity. Coming to the results, they had identified 170 patients, out of which 84 were assigned to metformin and 86 were assigned to, 84 were assigned to no metformin and 86 were assigned to metformin. Out of the no metformin arm, 3 were excluded. So final analysis included 81 patients to the no metformin arm and 86 patients to the metformin. Coming to the demographic characteristics, they were balanced between the two arms. The median age of population was 64 years. The adenocarcinoma and squamous carcinoma were in equal proportions. Two-thirds of the patient consisted of stage 3A disease. Coming to the compliance, planned radiotherapy doses were delivered in around more than 90% of patients. The central review of radiotherapy plans shows that the 97% of the plans were concluded and the planning was done as per the protocol. Coming to the chemotherapy compliance, around 80% of the patients in the both the arm completed the concurrent and the consolidation phase of the chemotherapy. Metformin compliance, around 63% of the patients completed the planned course of metformin for a concurrent and the consolidation. The most common result for discontinuation of the metformin was the side effect. Coming to the survivor outcome, the median follow-up of the cohort was 27 months. There was no difference in the survival in terms of progression-free survival, overall survival, local regional recurrence, or a distant metastasis between the two arms at 1 year and at 2 years. In the factors affecting the outcome, the higher stage had a worse PFS, like 3B had a significantly inferior PFS as compared to the 3A stage. These are the Kaplan-Meier curves for the progression-free survivor, overall survivor, local regional recurrence, and the distant metastasis, again showing that there was no difference between the two arms. Coming to the toxicities, both the arms had an equal toxicity except for diarrhea, which were higher in the metformin. 17% reported more than grade 2 diarrhea as compared to 10% in the no metformin. Coming to the limitations of the study, metformin without modification, dose modification was given only in the 39% of the patients. Compliance and the tolerance to the metformin may be the additional variable affecting the results. Hence, there was no demonstrable benefits. Also, this study was not a placebo-controlled trial, primarily owing to the cost constraints. So they had planned as the open-label trial. Coming to the conclusions, addition of metformin did not improve the survival outcomes for patients with local regionally advanced NSCLC with chemoradiation. Survival outcomes were better as compared to the data from the previous randomized trial, probably due to they included non-diabetic patients only. However, they are postulating that recent trials suggest that addition of metformin to TKI immunotherapy may have a synergistic effects. So this can be explored in the further trial. Thank you.
Thank you, Dr. Nikhil. One way it is good that we got some data about the metformin and a prospective data. Was there any hypoglycemic problems? The studies tells anything about it?
No, sir. They didn't report significant hypoglycemia.
Nothing with it. Thank you. Any other queries from the audience, participants?
No, I don't think so. Any other queries are
Thank
there?
you. Thank you. We'll have the next speaker.
Thank you, sir.
For the next talk, we'll invite Dr. Pranav Chadda from Mumbai for the next abstract presentation.
Welcome, Dr. Pranav.
Shall we share your slides? We have Dr. Pranav Chadda's slide. Dr. Pranav, you are not audible. I think you are mute.
Hello, Dr. Pranav, can you hear us, please? You need to.
Yes, I can.
Yeah.
The thing is, I'm not able to share my screen with you.
We can see your screen now, sir. We can
All
see
right.
the slides. If you can make it on a slideshow,
Now, can you
fantastic.
see it?
Oh, yes, sir.
Right.
All yours.
All right.
Maybe
Thank
a volume a little higher, sir. Otherwise, everything is set. Thank you.
Can you hear me now? Am I?
Very well, sir.
I'm nicely audible. All right. So this is an abstract that I'm supposed to present. It's the role of gefitinib, an anti-EGFR inhibitor with concurrent thoracic radiotherapy in an unresectable, locally advanced non-small cell lung cancer with EGFR mutation. It was from a West Japan oncology group, and it was published this year in May 2021 in the Journal of Thoracic Oncology. The background that around 10% of patients with locally advanced NSCLC harbor an EGFR mutation, and there is a declined benefit with an immune checkpoint inhibitor in this population. Gefitinib, an EGFR tyrosine kinase inhibitor, exhibited a radiosensitizing effect in the preclinical models, and therefore in patients with non-small cell harboring EGFR mutation, gefitinib monotherapy overwhelmed chemotherapy, and there was an evidence for that, and that led to the idea for this trial that chemotherapy could be replaced by gefitinib. It was an open label, multi-institutional, single arm phase 2 trial, and the patients included were chemotherapy naive with an exon 19 deletion or an exon 21 L858R point mutation. Patients were treated with gefitinib, 250 milligram per day for 2 years, plus concurrent thoracic radiation, 64 gray 32 fractions, to assess the efficacy chest and upper abdominal CT every 2 months during the first 6 months and at least every 6 months thereafter. Additionally, full staging chest and upper abdominal CT, brain MRI, PET CT were mandatory at first 1 and 2 years. The primary endpoint was PFS at 2 years. So patients flow in the study, 28 patients were registered, 1 patient was excluded because of the inadequate informed consent. Therefore, 27 patients finished the study treatment, 21 patients discontinued, 12 due to adverse events, 7 due to disease progression, and 2 due to patient's will. So only 6 patients completed the entire treatment. The baseline patients' characteristics were the median age was 67 years, with an unequal ratio. The female gender was more. The ECOG was evenly balanced. The ECOG was sort of 0 and 1 were taken. The histology was exclusively adenocarcinoma, with the median follow-up was 51.8 months. The results: the PFS rate at 2 years was 29.6%. It was a one-sided confidence interval. Median PFS was 18.6 months. PFS rate at 1 year was 66.7%. PFS rate at 2 years was 33.3%. Subset analysis did not reveal any difference among the gender, smoking history, type of EGFR mutation, and the clinical stage. The tumor shrinkage only showed a complete response in 3 patients with a partial response in 19 patients. The overall response rate was 81.5%, and the overall survival was 61.1 months. The Kaplan-Meier showing the overall survival, the PFS and the overall survival. Adverse events, not too many. The skin reactions, or all more so, in except for the increased enzymes, none whatsoever clinically as such. The treatment exposure, patients did develop pneumonitis, 8 patients. There was a disease progression as well, which was in the brain. I'll tell that later. Grade 4 adverse events were 3. Patients will not to take further treatment. And gefitinib was given for a median days of 332 with a range of 26 days to 736 days. And dose reduction was also there. Thoracic radiotherapy was 62.9, the range being from 38 gray to 64 gray. The V20 lung, it was 26.5 gray with a range from 14 to 35 gray. Site of initial relapse, within the radiation field, there was only sort of one relapse in the primary site and one at the lymph node. The brain only showed 12 extra thoracic sites. Post-study treatment, patient underwent a second-line erlotinib with subsequent therapies. One patient underwent a checkpoint inhibitor treatment and one with immune checkpoint inhibitor. They were also given cytotoxic chemotherapies, third line, and stereotactic radiation was done for the brain survival, brain metastasis. I'm sorry. So the important findings are that, as revealed in the preclinical study, EGFR TKI plus revealed its activity. Very few relapses within the radiation field. Substantial proportion of patients relapse with the solitary brain mets. Most of them received stereotactic radiotherapy at the time of progression, and their OS was significantly better, suggesting the importance of managing brain metastasis to overcome a newer, this study was prior, so a newer thought was concerning the osimertinib, which has a better brain or a CNS penetration. But there was also a concern with regards to the pneumonitis, which osimertinib has a higher rate with the thoracic radiotherapy. So brain metastasis and other metastasis of the brain metastasis tend to do better with the role of or with the help of stereotactic radiotherapy. Limitations: it was a single arm trial, cannot eliminate the selection bias, small number of participants, efficacy outcomes had wide confidence intervals. Nevertheless, the PFS result is still valuable. Needed 5 years to enroll a significant number of patients, as it is uncommon to investigate EGFR mutations at this time of the study. This could have been affected by application of a newer agent, namely immune checkpoint inhibitor osimertinib. However, this population was typically insensitive to ICS, and only 2 patients received osimertinib. This prospective study revealed the tolerability and the possible efficacy of gefitinib plus concurrent TRT in patients with locally advanced NSCLC having an EGFR mutation. Thank you.
Thanks, Dr. Pranav. Only 6 completed the treatment.
Only 6, sir. It was I don't know, sir. It was only a 6 patient that had completed the study. Yes,
so, but
sir.
they have given a lot of important data, this, that, and all. You feel
Yes,
it's really worth it to take this data further? Because
No.
number completed is very small, I feel.
Very
Even
small.
though we expect a lot like cetuximab in head and neck, something
Yes,
if it comes, it will be really worthwhile. But somehow
Yes.
I feel that there is, but maybe it is the reason that the organizers, we wanted to bring it out to the audience. Yes, there's a
Yes.
study like that.
Yes,
Thank you,
and
Dr. Pranav.
thank you,
Good.
sir.
Any other points you want to mention on this?
So it was more of a concurrent as well as adjuvant gefitinib, which was going on for 2 years. The study was planned in such a way. The rationale of using gefitinib for such a long time, the rationale was given by the authors in the paper.
Thank you. Thanks a lot.
Thank you, sir.
Thank you,
We
Doctor.
can have next speaker, Dr. Nilesh.
Good morning, sir.
Ram, welcome, Nilesh.
Good morning. Can I request the organizing team to just put up my slides?
Yeah, we will share it.
Yeah, good morning. I'll be presenting the Key Link 012 study. This is by Salma Jabor from the Rutgers Cancer Institute, New Jersey. And this study was presented at the ESMO Virtual Congress 2020. Next slide, please. So we know that for patients who have stage 3 unresectable, locally advanced lung cancer, since the last few years, there has been a standard of care, and the standard of care has been durvalumab. So durvalumab, which is an anti-PD-L1 antibody, is approved for unresectable stage 3 NSCLC without disease progression following concurrent CTRT. So concurrent CTRT remains a standard of care, and maintenance therapy after this in patients who have not progressed is today the standard of care for patients with stage 3 lung cancer. Pembrolizumab, which is also an anti-PD-L1 antibody, is the standard of care for those patients who have metastatic NSCLC, either as monotherapy or in combination with chemotherapy, depending on the biomarker expression. There have also been early trials of pembrolizumab in the setting of stage 3 lung cancer, where it is combined with concurrent CTRT, either given concurrently or subsequently. And this has shown acceptable tolerance as well as a promising PFS in patients with unresectable stage 3 non-small cell lung cancer. Now, these initial studies have been smaller studies and single-arm studies. There is also early data that suggests that PARP inhibitors, when combined with the anti-PD-L1 molecules, can enhance the treatment effects. So the KeyLink 012 is a global phase 3 randomized placebo and active controlled double-blind study that evaluates pembrolizumab with concurrent CTRT, followed by pembrolizumab with either placebo or PARP inhibitor olaparib, that is group A and group B, versus the standard of care, which is concurrent chemoradiation, followed by durvalumab, which is group C. And this is in patients with unresectable, locally advanced stage 3 lung cancer. So this is the study design. patients more than 18 years who have stage 3, either A to C, non-small cell lung cancer, and who are ineligible for any curative surgery, and who have a performance status of 0 to 1, are randomized into 3 groups. Group A is the pembrolizumab with concurrent CTRT, followed by pembrolizumab for a period of 1 year, along with olaparib as a placebo olaparib. Group B has a similar design, but olaparib is added to this combination for a period of 1 year. And Group C is a standard arm or the control arm, which includes concurrent CTRT followed by durvalumab for a period of 1 year. The choice of chemotherapy, can I go to the previous slide, please? The choice of chemotherapy is basically a platinum doublet. So it is cisplatin, etoposide, and paclitaxel for the squamous, and it is cisplatin and pemetrexed for the non-squamous. Radiation is standard 60 gray during cycle 2 and cycle 3. Next slide, please. So just to note in the exclusion criteria, in view of the drugs that are being co-administered with radiation in this setting, patients who have a history of pneumonitis or interstitial lung disease, as well as patients who have features suggestive of AML or MDS, were excluded in this group of patients. Next slide, please. So the primary objective was to evaluate the following in Group A and B versus Group C. One was the PFS as per the blinded independent central review, as well as the overall survival. And the secondary endpoints included safety and tolerability, the overall response rate, the duration of response, and several patient-related outcomes. Next slide, please. There were also some exploratory objectives. So they will be assessing the circulating tumor DNA during the course of its treatment and correlate this with efficacy endpoints. They would try to identify molecular biomarkers that may indicate clinical response or resistance and safety. They will also evaluate the effect of PD-L1 expression on these similar efficacy endpoints, as well as evaluate the following in Group A, B, and C regarding the PFS2, as well as the time to the first anti-cancer therapy and the second anti-cancer therapy, and several other economic models. Next slide, please. So this presentation was a trial methodology presentation. This study has been initiated just last year in July 2020 at 204 sites in 24 countries and is currently undergoing recruitment. So the earliest we would probably get any interim result would be somewhere in 2024 or 2025. But there were some important points that this trial has tried to address. And can I have the next slide, please? So as I went through this trial, I thought that there were 3 important questions that this trial is trying to address. The standard of care today for stage 3 non-small cell lung cancer that is unresectable includes the use of chemoradiation as the main treatment. And in patients who have stable disease or who do respond and do not progress, after a period of 2 months, these patients are put on maintenance durvalumab. Now, there is a problem in this, in that the IO or the anti-PD-L1 drug is initiated much later, almost 3 or 4 months after diagnosis. And from our data in metastatic non-small cell lung cancer, we do know that earlier use of immunotherapy will always be important in decreasing the risk of distant metastasis as well as in preventing early progression. So can we initiate the immunotherapy right at the diagnosis along with concurrent CTRT? That is one important question that this trial is going to address. For so many years, the trials tried to segregate and keep the radiation separate from the immunotherapy. And the main reason was the concern or the risk of pneumonitis. So the same author, Dr. Salma Jabbour, this year in JAMA Oncology has presented the Keynote 799 study, which was a phase 2 open label trial in stage 3 non-small cell lung cancer, where patients were treated with pembrolizumab along with chemoradiation, followed by pembrolizumab, in a similar way as this trial has tried to address. And in that trial, the incidence of pneumonitis was 8% in the squamous arm and 6.9% in the squamous plus non-squamous arm. And this incidence of pneumonitis between 6 to 8% is comparable to that which is achieved by that is seen in patients who receive single agent pembrolizumab or those who just receive chemoradiation. So what is important is that addition of radiation does not addition of of pembrolizumab would not increase the risk of pneumonitis when given with CTRT. So that is the second important point. Third, can I go to the next slide? Yeah. So the third important point was the rationale of combining IO with PARP inhibitors. So similar to breast cancer and ovarian cancer, there have been several studies that have shown that homologous recombination genes, including the ATM, the BRCA1 and the BRCA2, have been found to be frequently mutated in lung cancer patients. And these are somatic mutations. So there was a study where across tumor types in lung cancer, the prevalence was as high as 34%. And we know that PARP inhibitors selectively target cancer cells who have DNA repair deficiencies, like those caused by the BRCA1 mutations, and in lung cancer specifically, the ERCC1 defects, which also causes an impaired DNA repair. And there is strong preclinical rationale for using PARP inhibitors as an immunomodulatory drug in appropriately selected molecular populations. So PARP inhibitors have also shown to potentiate the interferon-induced PD-L1 expression, not only in cell lines, but also in fresh patient tissue. So this is an intrinsic concept. Can you add the benefit of PARP inhibitors as an immunomodulation as well as in patients who have HR gene mutations? So these are three important points that this trial tries to address, and it will take time, almost 3 to 4 years, by the time we have some interim results. But I think it is a very interesting study, and I would look forward for its analysis. That's my last slide. Thank you so much.
Yeah, thank you, Dr. Nilesh.
Thank you, Nilesh. The number of cases they have planned is somewhere around 800 plus.
Correct.
And multi-centers all over the world. Are you or TMH a part of the study?
So I don't think any center in India is a part of the study. From what I could understand, most of them are China, Japan, and North America.
Oh, okay.
But I'm not specific. I'm not very sure.
Okay, okay. Because in India, one of the common cancers and again, one of the common stages, maybe cost-wise, any comments on this?
So I think cost is a major limitation for most of our patients because irrespective of which IO is used in this setting, it does become expensive for most of our patients. Having said that, this is one group of patients who actually sit on the borderline between cure and incurable disease. And this is the best we can offer as of date in this setting.
Thank you. My co-chair, please. Thank you, Dr. Nilesh.
Thank you, sir.
Excellent talk by all the previous speakers. It's really good to understand the changes which are going there. And the part which is most important in this lecture was that we should think of BRCA receptor in few of our patients. That may help the patients.
Yeah.
Next speaker, please.
Dr. Piyush Bajpayee, he is head of the department Delhi, basically, Manipal Hospitals.
Yeah. So I hope I'm audible clearly.
Yeah, slides are visible and audible.
Yeah. So my presentation is on Pacific real world study. The treatment duration and interim analysis of progression-free survival was presented for this real world study in this ESMO Congress. So we all know this Pacific study was there, and which did show that durvalumab given in stage 3 NSCLC non-resectable who were treated with concurrent chemoradiation, durvalumab given with a placebo control was a comparator. So there we did see that 5-year overall survival was improved over there, and progression-free survival again was there. So PFS was nearly 16 months in the updated, 17 months nearly in the updated analysis versus placebo of 5.6 months. So this has almost become the standard after this presentation of this trial. However, real-world studies have their importance because whether the results of the trial are translated into real-world practice, that is very important. So this was basically the extended access program which was available. And this study was done between September 2017 and December 2018. Up to December 2018, at least the patient who were enrolled, and they were stage 3 NSCLC who received chemoradiation, and regardless of the tumor PD-L1 expression. So they got durvalumab 10 milligram per kg every 2 weekly, the trial protocol. And they were actually analyzed. So the data presented over here was PFS events. So nearly 1,400 patients were included, and 290 active sites with 11 participating countries were there. So again, the primary investigator, SS, PFS, and OS were the primary endpoints. So talking about the patient characteristics, well, we see that the age less than 75 was nearly 89%. And then stage 3A, if you see over here, was nearly 43%, slightly lesser than what was there in the trial. The histological subtype was adenocarcinoma predominantly in 63%, and PD-L1 expression more than 1% was there in nearly 72% patients. Now, one thing important over here was median time to durvalumab initiation was 56 days. So this is more than the usual 6-week time as per the protocol. So the median durvalumab treatment duration was nearly 11 months, and patient received a median of 22 durvalumab infusions. So talking about median follow-up duration in this PFS analysis was nearly 23 months. And what was seen was that the median PFS turned out to be 21.7 months, which was actually higher than the actual trial. So this is, of course, analysis in the real world setting, and biases could be there. So definitely this could be the one factor because of biases we could see the slightly increased PFS. But the PFS was definitely higher in PD-L1, more than 1% in subgroup analysis. In stage 3A, the PFS was higher. It went up to 23.7 months as compared to 19.2 months in stage 3B and C. Chemo radiation concurrent, again, the PFS was higher as compared to the sequential. And of course, adenocarcinoma, again, non-squamous histology, PFS was higher as compared to squamous. So nearly 16.7% patients actually discontinued the treatment because of any adverse effect. 47% completed the actual planned treatment. And the cause of discontinuation was, again, pneumonitis as the most common cause in nearly 18% of the patients, where moderate event was nearly 8.4%. So this particular real-world study demonstrated that the consolidation durvalumab after chemoradiation for a median duration of 11 to 12 months, 11 months over here, is effective in large real-world cohort of patients with unresectable stage 3 NSCLC. The median real-world PFS turned out to be higher, 21.7 months, as compared to the trial. And challenges with collecting real-world PFS data limit comparisons between the real world and the actual trial. So the effectiveness of durvalumab after chemoradiation in the analyzed subgroups were generally consistent with the previous specific trial, including the PD-L1 subgroups. And rates of treatment discontinuation due to adverse effects, 16.7%, were definitely higher, and disease progression were consistent with what was seen in the Pacific trial. Pneumonitis and ILD events were manageable, and mostly, and 70% nearly actually got steroids. So they were manageable and mostly moderate in the severity, which was actually seen in the Pacific trial. Thank you.
Very interesting, Dr. Piyush. I can have a few queries.
Yes, sir.
Your personal practice cost insurance, how does it look like in durvalumab? The data appears to be fairly interesting in a real world.
I think so. It's a good option looking at the PFS, grim PFS of stage 3B, 3C, where most of the times we give chemoradiation. So it is an important option that we have. Of course, looking at the survival in such small curative edge that we get, I think so. It is worthwhile, sir, to give this to our patient as a option.
Affordable in your setup? They take it?
That of course is a challenge, sir.
Okay.
And especially when we talk about pneumonitis and also definitely that becomes a challenge.
Okay.
Yes.
Thank you. Thank you.
So I would like to invite now we have a session sponsored by AstraZeneca, a case-based panel discussion, optimal management of stage 3 NSCLC, for which I would like to invite Dr. Sushant Mittal, senior consultant medical oncologist, Action Cancer Center, New Delhi, and I will like to introduce the panelist. Dr. Ramakant Deshpande sir, he is a surgical oncologist, executive chairman, Asia Cancer Institute. Dr. P.K. Das, a senior consultant medical oncology, Apollo Cancer Institute, New Delhi. Dr. Anil Tabdewal, assistant professor, radiation oncology, Tata Medical Center, Mumbai. Dr. Sridhar P.S., senior consultant, radiation oncology, HCG, Bangalore. Dr. Gagan Saini, director, radiation oncology, Max Super Specialty Hospital, Delhi NCR. And Dr. Ashish Joshi, consultant medical oncologist, Nanavati Super Specialty Hospital, and director, Mumbai Oncology Care. Over to Dr. Sushant Mittal.
Good morning everyone, and I hope the Sunday academic feast is good for everyone. Dr. Gagan seems to be jogging or walking in a park. That's great. So can I have the slides, please?
Dr. Sushant, Dr. Das is not there.
Okay, fine. No issues. So I'll start with the case presentation. In March 2018, 52-year-old gentleman presented with cough, weight loss, and X-ray had these lesions. Next slide. And the CT scan was suggestive of a large heterogeneous enhancing lesion with necrotic component involving the apico-posterior segment of the left upper lobe. Along with that, few sub-centimeter and enlarged mediastinal lymph nodes were likely representing metastatic involvement. A small nodule is seen along the right upper lobe, which may represent a post-infectious or metastatic nodule. So, as expected, we did a PET scan. Next slide. And it showed a mass in the upper lesion, 7.6 versus 7.5 into 8.3 in the left upper lobe, abutting the costal and the mediastinal pleura in the apical segment. And the mass is abutting the arch of aorta and encasing the left upper lobe bronchus with mediastinal lymph nodes on the right side, likely a neoplastic etiology. So, for the patient first goes to a surgical oncologist. So, Dr. Deshpande, sir, how would you like to go ahead with this, sir? So, you're muted, sir.
Hello, this is a 3B stage, so obviously not a primary surgical candidate unless and until is part of a clinical trial. So I would, in the joint clinic, I would say that I will hand him over to the medical oncologist and the radiation oncologist.
Thank you, sir. So Dr. Ashish.
Yeah. So I think as sir has very rightly mentioned, this is a stage 3B disease. We have got a contralateral mediastinal nodes. So this patient will definitely go in for a concurrent chemoradiation as a standard of care.
Great. So next slide, please. We did the biopsy and it was poorly differentiated adenocarcinoma. IHC was suggestive of this only. And so the diagnosis was T4N3M0, stage 3C, with the FDG avid contralateral mediastinal lymph nodes. So Dr. Gagan, sir, what would you like to have next information?
Okay, I think all the information is complete. I would just maybe if I were if I were there, I would probably examine the PET CT films more closely, as in just trying to see if any of those mediastinal lymph nodes require any EBUS or some sort of a histopathological confirmation before we label it, because not just because of to change the decision. I guess it still stays T4 and not really taking it away from chemoradiotherapy. But for a radiation oncologist, sometimes taking contralateral nodes means increasing pneumonitis. So I would just do that. So since you were asking what more information I would like, I would probably examine them. But this is an academic discussion. So assuming that all these are what they are, we would start planning the patient for radical radiation therapy to a dose of 60 gray by making the appropriate cast and doing appropriate 4-dimensional CT scans, etc.
If I may interject here, though I said that this is not primarily a surgical case, I would still, in the appropriateness of the investigation, an EBUS would be in order before you take the final call.
So Dr. Ashish, would you like to do an EBUS in your practice? Do you do for such patients?
So typically, if the nodes are quite conspicuous and FDG avid, I think for academic discussion, it is often should be prescribed. But technically, I think these patients go in for a concurrent chemoradiation upfront.
Okay, great.
No, I wouldn't disagree. I wouldn't disagree, sir. The only reason why I was insisting on having this EBUS or whatever is appropriate for the lymph nodes and in terms of safety was the fact that sometimes the contralateral nodes, they increase the volume so much for radiation therapy that it just increases the possibility of pneumonitis manyfold. So that was just a thought. So that was it. But yeah, we should start planning for concurrent chemoradiotherapy.
So Dr. Sridhar.
Yeah, I agree with all the panelists. Probably one thing extra I will do is I would like to make sure that the MRI brain is also done to make sure there is no mets in the brain. So that is one thing. Otherwise, it's a clear cut for concurrent CTRT. Yeah. So the elective the mediastinal nodes are not irradiated. So I won't be worried about because it's only the involved nodal RT what I am going to give even to the contralateral node. So I'm not be very keen about if there's a PET avid, I would like to go ahead and irradiate those areas only. No other nodes, only PET involved areas I would like to include.
So do you routinely do MRI brain?
Yeah, I do.
In non-small cell also you do routinely?
Yeah, all NSCLCs, even in the stage 1, especially when I'm considering for an SBRT setting kind of a things, even in this case, as in the second phase, if I wanted to boost these areas, my patients with lung cancers will have a MRI brain screening.
So Dr. Anil.
Yeah, hi Sushant.
Hi. So how would you now next slide please? So what's the intent for this treatment in this case, and how would you like to achieve?
So the intent of the treatment is still curative, and as far as how would you achieve the same is as the standard of care currently worldwide is the current chemoradiation therapy followed by durvalumab. As per the PACIFIC trial, and as the previous speaker has already shown that the median progression-free survival in real-world practice has actually improved from the PACIFIC trial itself. So we should see a median progression-free survival improvement and hopefully a 5-year overall survival rate of not less than 40%. So approximately 43% was the 5-year overall survival.
Yeah, we'll come to that. Now, what I want to ask is you are in Tata and Dr. Gagan is in private practice. So how would you like to go about? You would like to go sequentially, you would like to go concurrently, looking at the burden of patients you have in Tata and how availability of the machine for the patient.
See, as far as the fitness part of the patient is concerned, we would like to do pulmonary function test as well as the effort tolerance. We'll ask the effort tolerance of the patient. If the pulmonary function test is good and the patient is good without any comorbidities and does not cause any significant toxicity with concurrent chemoradiation therapy, the patient will go for standard for concurrent chemoradiation therapy.
Great. So next slide.
I don't know, Dr. Sushant. I just wanted to make a point that each and every meta-analysis, and including this one real-world data which was just presented, everything has always shown that concurrent chemoradiotherapy is so much superior over sequential. It's always been statistically significant in meta-analysis, systematic reviews. So giving a chemotherapy straight upfront to a stage 3B or a 3C patient generally is counterproductive to the patient and does not help, unless of course it's decreasing the tumor size to such a level that some pneumonitis is prevented. Now this is an upper lobe lesion, so I am not worried about that part. So the parenchymal pneumonitis, because geometrically from whatever that one slide I could see, we can do safe radiation to the parenchyma. So we don't need to reduce the size. So I would go for concurrent chemoradiotherapy for this patient.
Dr. Ashish, how commonly do you do NACT followed? How commonly do you do sequential or concurrent?
Yeah.
What's the take?
So I think jury is quite clear here that the concurrent is superior to sequential. I think it's been proven beyond doubt. But what actually happens in our clinic sometimes is the bulk of the tumor, we refer a patient to a radiation oncologist and probably we get a feedback that the bulk of the tumor is so big that the radiation volume is very high. And then probably there is a request then to, give some sort of neoadjuvant chemotherapy to downsize the tumor and then go in for a concurrent chemoradiation. So this practically happens. But typically, if you ask if radiation oncologist is comfortable, the baseline lung functions are good, then concurrent chemoradiation could be the first option for these patients. But often, for a few indications, there has been a request to start neoadjuvant chemotherapy, and that is the time when we do it.
So, Dr. Sridhar, if the patient performance status was 3 and he has gone to a government hospital where the disease burden is low, very high, and the radiation appointments are not available, would you still request the radiation oncologist to please somehow arrange an appointment for this patient, or you will start with the neoadjuvant?
See, that's a very tricky situation. Like it all depends on where the patient lands and what is the comfort level. Answering some of the questions, there's one question that mediastinal nodes comes negative.
You're muted.
Sorry. So the mediastinal node comes negative. We won't, in a mediastinoscopy, we don't want to include that in the radiation field. That's very clear. If you are not at the mediastinoscopy and it comes, if the PET uptake area will take it as positive. That is number one. Number two, to answer the question, the neoadjuvant CT, as Dr. Gagan says, so stage 3B with a concurrent CTRT and followed by the further management with IO may be more appropriate rather than going for the neoadjuvant CT as such. Then the scenario of a logistics where you are talking about there is a workload is more and all. So that time, whatever is appropriate at that point of time, adding the neoadjuvant may not be a bad idea rather than not treating the patient.
Dr. Kannan here, can I add up a few points?
Yes, sir, please.
The practical experience, I perfectly agree with Dr. Ashish Joshi, who brought up a point. Recently, we had 2 cases wherein we told the patient appears very large, we have to do the DVH, we will do it. And we did the DVH as a part of the planning. We found it extremely high, V20, V5. There's a lot of this dose volume equivalence recall. We have to cancel it. We have sent the patient for NACT. So the point which Ashish Joshi made, we have all the facilities. We don't have a waiting time, nothing of that sort. But when we expect that the lung toxicity or cardiac toxicity may be higher than the expected, we do and we have done cases NACT followed by concurrent CTRT. Thank you.
No confusion.
So next slide. So that's what I was trying to bring in, that a multidisciplinary team discussion is very important for the survival of the patient in stage 3 lung cancer. And it has been proven in this study +1, which shows that the median survival of the patients who were treated after MDT discussion was 41 months versus without MDT was 25. So such a significant improvement in the overall survival has been there when so many brains work together for the betterment of the patient. So the takeaway message is MDT approach gives the best outcome for the patient of stage 3 NSCLC. And I think everybody would agree to that. So next slide. So now stage 3 is a very heterogeneous disease, and I'm sure this slide is small, but we all know that we have different variety of stage 3. So what's the difference in the management of N1 versus N2? So I'll start with Anil, Dr. Anil.
So if you are asking about stage 3 and 1, then it's a different thing. First of all, the primary tumor resectability has to be determined. If the primary tumor is resectable and the thoracic surgeon feels that the patient is operable, then we should go ahead with the surgery. There is no doubt about that. The only area where there is very heterogeneity as well as controversy is the N2. So generally and largely, patient with a single station N2 can also have a good surgical outcome as well as with the CTRT. If you remember the paper by Kathy Elben et al., so which was published in 2009, so it also showed that in a subset analysis, the patient who underwent lobectomy with a single station N2 has got a better overall survival as compared to pneumonectomy as well as multi-station. So if it's a, then probably yes, the neoadjuvant chemotherapy followed by surgical assessment is required. If the patient is having multi-station N2, then upfront concurrent chemoradiation therapy will be good enough.
So next slide, and Deshpande sir, how would you go ahead with N1 disease, stage 3 N1 disease, sir? Sir, are you there?
Sir is muted.
Hello. Sorry. Hello.
Yes, sir. We can hear you, sir.
See, if it's a preliminarily diagnosed T3N1, then it's a primary surgery. If it's a N2, still.
So you're muted, sir. So you're muted, sir. Yes, sir.
Hello. Can you hear me now?
Yeah, yes, sir. We can hear you now.
Yeah, if it's T3N1, then it is primary surgery. And if it is T3N2 single station, then it will be primary surgery. If it's multi-station, then it will go in for chemoradiation.
Thank you, sir. Next slide, please. Next slide. So next slide. So to continue with the case, this patient received neoadjuvant chemotherapy with paclitaxel. He had some reactions with the paclitaxel, so it was changed over to nab-paclitaxel, and he completed the treatment, and the PET scan showed a partial response to the therapy. Next slide.
Excuse me, Dr. Shushan, you have next 5 minutes to finish.
Yes, sir. That's why I'm going through it. So now the patient had a partial response, and he was given concurrent CTRT, and he tolerated the treatment well. He completed the treatment in November 2018. So the doses are adequate, radiation doses are adequate, Dr. Gagan, Dr. Anil?
Yeah, they look adequate. They look adequate. We should actually try to push in as much dose as possible without causing pneumonitis. Although the ASTRO recommendations kind of, put a ceiling to 60 gray, but because, there has been some meta-analysis and other things which show that it does not matter. But for an individual case, if we can push in more dose, like even I would have done for this case, because it was geometrically located in a location where we can push in more dose. This is a good dose.
So next slide. Next slide. We have discussed this. Concurrent radiation is better than sequential. Next slide. Next slide. So even after giving neoadjuvant and giving this doses, patient developed radiation pneumonitis. So Dr. Ashish.
Yeah.
Would you like to add Durva right now, or you'll wait for this radiation pneumonitis to settle down?
So typically, I would want the radiation pneumonitis to settle down, because I think in the durvalumab situation, and that is the only a point which comes in our way of giving adequate treatment. the incidence of pneumonitis is upwards of 16.3%, which is quite high. So I would, in this case, I would want to wait for pneumonitis to settle and then start on durvalumab. Otherwise, we would want to start it early.
So next slide. So still now, before Durva, we didn't have any consolidation chemo radiation for the post CTRT patient, and patients do keep asking us what should be done, doc, to prevent the disease from coming back. So now we have the answer of Durva. Next slide. So this was the study, we all know about it. Dr. Sridhar, how often are you able to enroll the patients in Durva after the radiation is finished? Well, you within 6 weeks or after 6 weeks, what's your experience?
Yeah, Dr. Kannan already asked that question, how practically the patients are affording and how it's
no, I'm not talking about the affordability. I'm talking, is it possible for you within 6 weeks you're able to enroll the patient to take up for the Durva?
Yeah, so 6 weeks is between 4 to 6 weeks is the time what I like to do it. See, among the radiation oncologists, the radiation pneumonitis is one of the things which is always a problem. It all depends on how much margins you are taken for that particular patient. If your margins are more than 1 centimeters and the low dose is like we talk about B20 and other things, so that is the one which is causing a more radiation pneumonitis. So if you are looking for the starting the immunotherapy as such, probably I would like to reduce the doses and keep my low dose area also the tight distribution. And 60 to 60, minimum 66 gray is definitely one. There is something called a simultaneous integrated boost. With that, I would like to give more insight than radiation dose to the periphery so that pneumonitis decreases. And 6 weeks is the time I would like to introduce the immunotherapy at any given point of time.
Great. Next slide. Next slide. Next slide. We have discussed pneumonitis. So this we know Durva is indicated and approved in India as a maintenance therapy. And next slide. Dr. Anil, I would like to ask you, when do you counsel the patient for giving durvalumab in your practice? At the beginning of the treatment or when you see the response and patient has achieved some response, then you counsel? Next slide. Next slide. Yeah.
Yeah, so if I can speak on the behalf of my medical oncologist, we counsel the patient upfront. So without looking at the response, obviously we will reassess the patient after the completion of CTRT, how the patient is tolerating and how the patient has had any toxicities or not. But we counsel the patient upfront. We look for the affordability. We look for the health insurance if the patient is having anything, so that the patient can be prepared for the addition of durvalumab as a maintenance therapy.
Dr. Ashish?
Yeah, I completely agree. I think counseling this upfront is very, very critical. Otherwise, if you get the story in between the arc of the treatment, then even if the patient is probably affording, he will probably not go for it. Correct. So I think counseling upfront is very, very critical. That this is an option which is there on the horizon, and if the scientific indications permit, we would want to include that in your clinical in the clinical scenario.
Especially when I totally agree with that. The roadmap has to be done upfront. That makes a lot of difference because like depending on the radiation pneumonitis and that if you start telling, it's always a confusion. And especially when a neoadjuvant setting like this, so it's always a confusion that you want to stop at 3 cycles or 6 cycles to complete. So that is another reason that I always prefer to do CTRT followed by maintenance durvalumab or other things upfront, rather than wait and watch. Like neoadjuvant, when we give neoadjuvant, there is always an issue about this, especially.
Thank you. Next slide, please. Next slide. Next. So this has shown a PFS benefit and an OS benefit. Both is there, and that's why this discussion is happening. Next slide. And take me to the last slide, take home message. Yes. So to conclude is that MDT approach gives the best outcome for patient with stage 3 and SCLC. CCRT gives a better outcome than RT alone or CT alone. Concurrently is better. It is the first and only approved immunotherapy to demonstrate a 5-year overall survival and PFS benefit, even at the end of 43 months. That's remarkable. And consolidation chemotherapy does not improve outcome. Durva should be considered, and it improves outcome irrespective of the PDL1 status. And this EGFR line, I like to ask Dr. Ashish, how often do you get or do you do EGFR or NGS testing in stage 3 lung cancer? That's the last question, and then we are over.
So typically we are not doing, sir, at this point of time, EGFR and NGS. In the sense, we even if we do it, we do not have immediate clinical implications. But large number of these patients, even if with Durva, are eventually going to become a metastatic disease. So that's where I think we will have a role of EGFR and PDL1 to go in. But now with this, currently I think just gefitinib data was produced. There is a concurrent pembro study which is going on. So I'm sure I think this clinical practice would eventually make a change. But as of now, I think if you look at typically at clinical decision making, that would not change my treatment. But I tend to do it for stage 3B patients in my clinical practice, because a lot of them then eventually become a metastatic disease, and that's where probably you would have an option.
So I also feel that EGFR status should be done, because the driving mutation, if it is there, then giving Durva in such patients, I don't know, it may not be helpful. Although we still have that LAURA study, it's still going on, in which we are giving osimertinib in EGFR positive patients. So that will answer the question. This study also had about 6% of patients who were EGFR positive. So with this, thank you all for having coming over on this Sunday morning. Thank you so much for an esteemed panel, and back to the organizers.
Yeah.
Thank you.
Yeah.
Yes, thank you, Dr. Sushant.
Yeah.
Thank you very much. Thank you.
Yeah. Thank you, Dr. Sushant and the panelists for the wonderful discussion. Thank you, Kannan sir, and thank you, Dr. Rakesh. Now for the next session, which is a neoadjuvant immunotherapy, I would like to invite Chairperson Dr. N.K. Warrior sir, Medical Director and a Senior Consultant Medical Oncologist, MBR Cancer Center, Calicut. And speaker for the first session, the first abstract, is Dr. Bowman Dabar sir, Consultant Medical Oncologist, Fortis Hospital, Mumbai. Over to Dr. Bowman Dabar sir.
I'm thankful to the organizers for inviting me today to speak on this topic, which is a very new topic and hopefully should become a standard of care soon. So first slide, please. Let's see if I can share the screen. I can show better probably. You all can go into the slide. Yeah. So today what I'm going to talk to you all is the role of immunochemotherapy, that is nivolumab with platinum doublet versus chemo alone when given in a neoadjuvant setup, that is those patients who have a resectable non-small cell lung cancer, and what are their surgical outcomes. Next slide. So just to introduce this topic, and as we were discussing so much about neoadjuvant chemotherapy, the facts are this big meta-analysis. What did it show? That neoadjuvant chemotherapy, when giving chemotherapy prior to surgery, that is chemotherapy plus surgery versus surgery, the 5-year survival rate was better by a meager 5% only. And there was no survival benefit if adjuvant chemotherapy was also administered. So neoadjuvant chemotherapy has a role, but the role is so marginal. So now coming to immunotherapy, what is the basic concept of giving immunotherapy in a neoadjuvant setup? We all know antigen presenting cells are the one which take the tumor load and present to the host T cells. And hence it is believed that when the tumor load is large, that is when we give neoadjuvant immunotherapy, there is a large antigen load that the APC would give to the T cells. And hence this is the antigen presenting cells, and hence it would elicit a stronger anti-tumor T cell response. That is the basic preclinical approach. And that is why, next slide. And that is why there are many phase 2 studies where you all can see single agent nivolumab, pembrolizumab, atezolizumab could give us a major pathological response of approximately, you can say it's from 20 to 45%, depending on what immunotherapy agents we use. The result looked most promising in phase 2 studies with nivolumab. And when immunotherapy was given along with chemotherapy, sorry, this is major pathological response only, there were the major pathological response jumped from 50 to 80%, depending on which immunotherapy agent we were using. And we all know, next slide, that we all use most of the time neoadjuvant chemotherapy starting from stage 1B to 3A. Next slide. So Checkmate 816 was also a study where they had used neoadjuvant nivolumab plus platinum chemotherapy for a resectable stage 1B to stage 3A non-small cell lung cancer. Next slide. And what they did was exactly this, that the patients who had stage 1B, more than 4 centimeters, to stage 3A without any sensitizing EGFR or ALK alteration, their 1:1 randomization between nivolumab plus chemotherapy or chemotherapy. The chemotherapy was the standard chemotherapy with cisplatinum, and depending on what the histopathology was, if it was a non-squamous cell, it was pemetrexed, and for squamous cell, they had used different regimens like docetaxel, gemcitabine, paclitaxel, everything. And it was a direct 1:1 randomization, and it was stratified as per stage 1B2 versus 3A. And PD-L1 status less than 1 or more than 1 and the sex. And after completing 3 cycles of chemotherapy, there was a radiological restaging, and surgery was done within 6 weeks post-treatment. And to give adjuvant chemotherapy was as per the standard of care. The primary endpoint was pathological complete response, that is by the blinded independent pathological review committee, and the event-free survival. The secondary endpoints were overall survival, and as I told you, major pathological response by blinded independent pathological review. And the key exploratory endpoints were overall response rate, feasibility of the surgery, and so on, so far and so on. Next slide. So as I told you, primary and secondary endpoints were by pathological assessment, and they were by the blinded independent pathological review, and they used the immune-related pathological response criteria, that is classically what is called as major pathological response. Major pathological response was the primary secondary endpoint, and what do we define by major pathological response is less than 10% of the residual viable tumor cells in the primary lung tumor and sampled lymph nodes. And pathological complete response, as we all know, is 0% residual viable tumor cells. And the second and the exploratory endpoints when they did a biomarker assessment was tumor mutation burden on circulating tumor DNA. Next slide. So coming to baseline characteristics, they were very well balanced between both the arms. Slightly higher, we can see here, squamous cell carcinoma in the chemotherapy, and slightly higher non-squamous cell in the nivolumab plus chemotherapy. And here, slightly more PD-L1 more than 50 were in fact in the chemotherapy arm, and slightly lesser in the nivolumab plus chemotherapy arm in the neoadjuvant setup. Next slide. Now coming to the primary endpoint, that is a pathological complete response. As you all can see, when nivolumab plus chemotherapy was used, there was 24% pathological complete response compared to chemotherapy, which was just 2.2%, a staggering difference of 21%. And major pathological response also, as you can see, was approximately 37% versus 9% only when chemotherapy was used. So this initial report from the checkpoint 816 showed that there was significant improvement in the pathological complete response, and there was a major pathological response also. And of course, tolerability, safety, I'll show you in my subsequent slides. Next slide. Here, if you see the minimal residual viable tumor that was left in stage 1B2 was 28% only when nivolumab plus chemotherapy was used in the neoadjuvant setup, whereas with chemotherapy, the residual disease was 79%. And in stage 3A, as I told you, randomization was between stage 1B2 versus 3A. And if you see the minimal residual disease that was there in stage 3A when nivolumab plus chemotherapy was used in the neoadjuvant setup was just 8% compared to 70% in patients who had received chemotherapy without immunotherapy. Next slide. So this is just some of the results, and what we can see here, that patient completing 3 cycles of chemotherapy were in fact more when nivolumab plus chemotherapy arm. As you all can see, it was approximately 94% compared to chemotherapy. In fact, more patients completed the 3 cycles, and pneumonectomy, but of course, these are very small numbers, were 17 versus 25. So much few patients underwent pneumonectomy when nivolumab plus chemotherapy was used. Next slide. So if we come to the pathological complete response, which was the primary endpoint, and here in the intent to treat population, that is in some patients in whom radiological progression was seen, or there was radiological no response, and they underwent surgery. In fact, still what we see here, that the pathological complete response was 24 compared to 2.2, as was the same. Whereas those who actually underwent surgery, it was still higher, 30.5 versus 3.2%. And the tumor, if you see the primary tumor only, it was 25.7 versus 2.2. So whatever you see, nivolumab plus chemotherapy did better as regards the pathological complete response was there, even if there was no radiological benefit seen. Next slide. If we see the subgroup analysis here, what we can see, that it be stage 1B or stage 3A, whatever, this nivolumab plus chemotherapy was better. And here also, whatever the PD-L1 expression, even with those who have PD-L1 expression less than 1, the benefit was there. However, with more than 50%, of course, the benefit was much more. And one more thing I want you all to see is, we always think that in neoadjuvant chemotherapy, we want to use cisplatinum as far as possible. But when nivolumab was used, in fact, carboplatinum was marginally better. I would not say marginally, but they were nearly same, I would say, because the numbers are very small. Next slide. So in the neoadjuvant setup, carboplatinum was also used. Now, if we see the overall response rate also, the nivolumab plus chemotherapy did better, 54% versus 37%, and radiological downstaging was also better when nivolumab plus chemotherapy was used. Next slide. And from the toxicity, when we think that we are adding nivolumab plus chemotherapy, we would think of more grade 3 and 4 toxicity, but somehow in this paper, if you all can see here, the chemotherapy arm grade 3 and 4 toxicity were more than nivolumab plus chemotherapy. The explanation I do not have really. Next slide. Next slide. And that is why right now there are many multiple studies going on, which I could go through the literature, and they were with single agent, nivolumab plus of course chemotherapy. Now all the studies which are phase 3 going on, because this was the first phase 3 study which is presented. So nivolumab plus chemotherapy or nivolumab with different immunotherapeutic agents with chemotherapy, standard chemotherapy was given. Some of them use 4 cycles, and there are many studies where adjuvant also immunotherapy being continued. So let us see whether we can improve really the overall survival for our patients when we use immunotherapy plus chemotherapy followed by adjuvant immunotherapy also. Next slide. So to summarize, CheckMate 816 met its primary endpoint of pathological complete response with addition of nivolumab to neoadjuvant chemotherapy for newly diagnosed resectable lung cancer patients, those who are stage 1B to 3A. Pathological complete response benefit was consistent across all subgroups. Major pathological response and overall response rates also improved. For event-free survival, which was a co-primary endpoint, the data is still immature, and I'm sure we'll be seeing that in a few years. Subgroup analysis, of course, which was not clearly mentioned, but it was shown that circulating tumor DNA clearance was more frequent when nivolumab plus chemotherapy was given versus chemotherapy. They did before starting and after 3 cycles circulating tumor DNA. And the circulating tumor DNA clearance was much better when this combination was used. So neoadjuvant nivolumab plus chemotherapy demonstrated a tolerable safety profile. As I showed you, grade 3 and 4 toxicities were not really high. In fact, were much less without adversely affecting the feasibility of surgery. So this was the first phase 3 randomized study demonstrating the benefit of neoadjuvant nivolumab plus chemotherapy for resectable non-small cell lung cancer. And thank you for your patient hearing.
Thank you very much, Dr. Dabar sir. Now I would like to invite next speaker, Dr. Rohit Swami, consultant medical oncologist from Jaipur. He will be speaking on neoadjuvant pembrolizumab for early stage NSCLC.
Hello, am I audible? My slides are visible?
He's there, he's saying. So you're not audible.
I'm not audible. Now am I audible?
Yes, sir.
Yeah. So good morning everyone. I am presenting role of pembrolizumab monotherapy in neoadjuvant setting in early stage NSCLC. So as you all know that checkpoint inhibitors prolong benefit for some advanced NSCLC patients, and early stage NLCLC 5-year survival rate in stage 2 is only 60%, and in
stage 3A is still 36% post surgical resection only, which are unsatisfying. And even adding adjuvant or neoadjuvant chemotherapy in this setting gives us only 5% benefit in 5-year survival rate. So in many different malignancies like melanoma or recurrent glioblastoma, it has been seen that giving checkpoint inhibitors in neoadjuvant setting is more beneficial than giving checkpoint inhibitor in adjuvant treatment. And neoadjuvant checkpoint inhibitor is being explored in several studies, but mostly in combination with chemotherapy. And we don't know optimal neoadjuvant checkpoint inhibitor regimen as a monotherapy in this early stage NSCLC setting. So this is a phase 1 study which explored the role of monotherapy feasibility and safety of pembrolizumab in early stage NSCLC. Primary endpoint of this study was safety of pembrolizumab in this setting and recommended phase 2 dose schedule and pathological response achieved after pembrolizumab neoadjuvant therapy. Secondary endpoints for recurrence-free survival, overall survival, and exploratory endpoints for exploration of mechanism of response and resistance to pembrolizumab in early NSCLC. So patients were enrolled in 3 cohorts, and cohort 1 dose schedule was to receive 1 cycle of pembrolizumab followed by surgery after 3 weeks if there is no dose limiting toxicity. Cohort 2 was planned to receive 2 cycles of pembrolizumab 3 weekly, and surgery was planned after 2 weeks. And in cohort 3, again 2 cycles of pembrolizumab 3 weekly, and surgery was planned after 1 week of last dose of pembrolizumab. There was also expansion cohort which was planned to receive dose schedule as per cohort 2 and cohort 3. So this study was started in January 2017, and expansion cohort target was increased to 29 to maximize trial validity. And enrollment was planned to be till January 2020, but enrollment was closed in November 2020, and 26 patients were enrolled because of slow recruitment in view of COVID-19 pandemic. So total treated patients were 26. Out of these 26 patients, 3 patients in cohort 1 received 1 cycle of pembrolizumab followed by surgery. And the patients in cohort 2, cohort 3 and expansion cohort who received 1 cycle of pembrolizumab was 23. Out of these 23 patients, 2 patients had severe adverse event and surgery was cancelled in these 2 patients. And 21 patients received both the doses of pembrolizumab, and 1 patient refused surgery among them. So total patients who underwent surgery were 20 who received 2 doses of pembrolizumab. And out of these 23 patients received 1 dose of pembrolizumab. So coming to the results, there was no dose schedule limiting toxicity in any of the patient. All the 26 patients, there was no DLT, and 21 patients received 2 cycles of neoadjuvant pembrolizumab. So in this study, total 7 patients achieved major pathological response, which was defined as less than 10% of viable tumor cell. And out of these 7 patients, 3 patients has complete pathological response. And all of these 7 patients belong to the cohort who received 2 cycles of pembrolizumab, and where surgery was done after initiation of treatment, that is after first cycle of pembrolizumab, after 5 weeks of first cycle of pembrolizumab treatment. And there was no correlation seen with the PDL1 status or tumor size or nodal status with attainment of major pathological response. And as I already told, all major pathological response were seen in the patient who has significantly long interval from initiation of pembrolizumab to surgery. So coming to patient characteristics, 7 patients attained major pathological response, and there was no correlation of attainment of major pathological response with smoking status or pathology or tumor size or nodal status or PDL1 status. Only significant factor was defined uh, which had significance in attainment of major pathological response was initiation of pembrolizumab to the surgery interval, and median interval in a group of patients who received major pathological response was 43 days as compared to 36 days in patients who were not able to achieve major pathological response. So coming to adverse event, around 81% of the patient had adverse event in this study, and serious adverse events grade 3-4 were seen in 35% of patients. And these serious adverse events were continuation of chest drain till post-operative days of more than 7. 2 patients had pneumonia, 2 had empyema, and one patient each has sepsis, myositis, myocardial infarction, myocarditis, encephalitis, and hepatitis. Treatment-related adverse event grade 3-4 were seen in 2 patients, and TRAE leading to treatment delay was seen in 1 patient, and discontinuation of treatment because of treatment-related adverse event was seen in 2 patients, but there was no dose schedule limiting toxicity in any of the patients. So after recommended phase 2 dose schedule was pembrolizumab 2 cycles at 3 week of interval followed by surgery after 2 week of last dose of pembrolizumab, and major pathological response was observed only in the patients who had 2 cycles of pembrolizumab and had surgery after 5 week of initiation of after first cycle of pembrolizumab. And when analysis was done in the patient who went with this schedule, this recommended phase 2 schedule, so there were 16 patients who received this dose schedule, and out of this, major pathological response was seen in 44% of the patient, and complete pathological response was seen in 19 patients. And
So, sorry to interrupt, just one more minute to go.
yeah. So relapse-free survival in the patients, which were 23 patients who received 2 doses of pembrolizumab, was 100% at 1 year and 92.3% at 2 years, and overall survival was 100%, and at 1 year and 2 year survival was 93.3% in all the population of the study, that is 26 patients. Median follow-up was around 23 months. So take-home message is that neoadjuvant pembrolizumab is safe and feasible. There is 8% rate of grade 3-4 treatment-related adverse event in this study, and there was no apparent relation to treatment surgery interval. Outcome in entire study group, 27% rate of major pathological response and 12% rate of pathological complete response, and 2 doses of neoadjuvant pembrolizumab at 3 week interval followed by surgery after 2 weeks of the last dose of pembrolizumab is recommended dose schedule for phase 2 study. And when we look, the 16 patients who received the treatment as per to recommended phase 2 dose schedule, major pathological response was seen in 44% and complete pathological response was seen in 19%. So pembrolizumab is feasible in neoadjuvant setting, and by the recommended phase 2 dose schedule, major pathological response attainment rates is around 44%. Thank you.
Thank you, sir. With this, we move to our next abstract. We invite Dr. Narmada R, consultant medical oncologist at Apollo Proton Cancer Center, Chennai, to review the next abstract.
Slides are not visible.
Narmada, are you there?
Just before she was there, I think still she's there, but any connectivity issue? Okay.
Dr. Narmada, you are still not audible. She's there on slides are moving for her end or okay, that means she's. Okay, I think we will take the next abstract.
Next, yeah.
Yeah. Uh, uh, we will start with the next speaker. I invite Dr. Prasad Narayan sir, senior consultant medical oncology and director of medical oncology, Site Care Cancer Hospital, Bangalore. He'll be speaking about neoadjuvant chemotherapy alone versus, neoadjuvant durvalumab with or without stereotactic body radiotherapy. Prasad sir,
Good morning. At the outset, I would like to thank the organizers for this
Sir,
opportunity. The next 7 minutes or so, I will be discussing about this study, which is a phase 2 randomized trial, which looked at neoadjuvant durvalumab alone or along with the stereotactic body radiotherapy in patients with early stage non-small cell lung cancer. So we know that there have been attempts at neoadjuvant systemic therapy, be it chemotherapy or immunotherapy recently in early stage lung cancer. But adding SBRT as an immunomodulator hasn't been tested in this context. And that is the basis of this study, which looked at pathological CR as the primary endpoint. And the PAT-CR rates usually with any sort of neoadjuvant therapy has been into the tune of 15 to 45% in different studies. So it's a randomized phase 2 single center study. One arm had 2 cycles of durvalumab, the other arm had durvalumab plus SBRT 8 gray, 3 fractions. Primary endpoint, major pathological response, which is defined as less than 10% viable tumor cells. 96 patients screened, 60 enrolled, 30 in each arm. And from this 30, 26 in each arm underwent surgery. So, and the post-operative treatment was radiation or chemoradiation as per the standard guidelines. What happened to those non-surgical patients, which is our main concern when we treat an early stage cancer with a neoadjuvant therapy? The single agent arm, 4 patients who did not undergo surgical resection, 3 were not explored because 1 refused, 1 had a stroke, 1 had bone metastasis. And the one who was explored had pleural metastasis, which is a common thing in lung cancer. When we stage a patient as early stage and we go in, we might find metastasis. In the combination arm, 1 patient who was not explored had a cardiopulmonary event. 3 of them were explored for surgery. 1 had lung mets, 1 had pleural met, and 1 had aortic invasion, which made it inoperable. Then from the demographics, what were the key points in these 2 studies? My first look was how many patients would have had a stage 3 disease. So almost half, 47 or 40% in both the arms had stage 3 disease. And invasive mediastinal staging. This study had a mandatory PET-CT and invasive mediastinal staging in those who were indicated. It was done in 40% and 43% respectively. Adenocarcinoma was more than squamous cell carcinoma. The key thing I would say, which might have influenced the result or not, we can't say, because both sides got the durvalumab, was the PDL1 expression. The PDL1 expression percentage more than 1 was 77% in the combination arm, which can explain the differential results actually. We can't say with a small study. EGFR mutant patients were almost 20% in both the arms. So major pathological response occurred in 2 patients, that is 6.7% in the monotherapy arm versus 16 patients, which is 53.3% in the combination arm. Among these 16 who had a PAT-CR, who had a major response, 8, that is 50% of them had a pathological CR, which is significant. So the study met its primary endpoint straight away. P-value is highly significant, and there is no need to even put a statistical calculation to find out this difference. What were the adverse events? The second cycle of durvalumab was withheld in 3 patients of the combination arm. Grade 3 or 4 adverse events occurred in 17% of the patients with monotherapy and 20% in the combination. Severe, serious adverse event, 2 in each group. One of pulmonary embolism and stroke in monotherapy. We discussed that in the patients who did not undergo surgery. And 2 SAEs of one of pancreatitis and fatigue in the combination arm. So a typical immunotherapy study, which with the AEs being described are very similar to that. So as a discussion, the trial met the primary endpoint, which was whether adding SBRT will improve on outcomes from durvalumab alone. And as I discussed in the demographics, there were differences in the PD-L1 positivity among patients in both the arms. Now, since this study had durvalumab in both the arms, PD-L1 was more in the combination arm, we don't know whether the effect of SBRT, just giving SBRT 8 gray into 3, was the impact in improved PAT-CR, or was there any effect of a immunotherapy radiation? And that cannot be done in this study, in such a small study, but definitely this rakes up this question of adding SBRT as a convenient mode of radiation along with 2 cycles of immunotherapy. The pathological response in the control arm was less than that is reported in other trials. One possible explanation could be the lesser number of patients with PD-L1 positivity, or there could be any other reason for that. So my take from the study, is it a study worth discussing? Yes, it is a study worth discussing, because the SBRT 8 grade to 3 is easily possible as a neoadjuvant arm. In this study, the patients were taken for surgery. The median time to surgery was 4 to 5 weeks, which is significantly less than most of the other neoadjuvant studies. So in that way, it is a simple study to be, and the period was not very high of the patients being diagnosed and waiting for the curative intent resection. And if 54% of them will get a major pathological response, it's worth doing something before surgery. And so definitely the study opens up a question of trying this in a larger study. And most of the studies which are looking at combination of chemotherapy plus immunotherapy combinations, there are phase 3 trials which are looking at this question in this era. So looking at a combination as a potentially curative intent therapy is something possible. I'm sure the surgical colleagues will now jump up on me, whether we can just give immunotherapy and radiation as a combination and cure more patients of early stage non-small cell lung cancer, be it adenocarcinoma or squamous cell carcinoma. So the study definitely met its primary endpoint, worth discussing and worth taking to a different level in a different design. That's my take from this study. Thanks a lot for the opportunity.
Thank you, sir. Before we go on to the next talk, I would like to request all the speakers for this session to stay on for the panel discussion. Now we go back to our abstract. I request Dr. Narmada, if connectivity is restored, to present her abstract.
So we can we call upon the next speaker, and Narmada said she will do it in the last.
Yes, sir. So we call upon the next speaker, Dr. Pradeep Vendrapati, Assistant Professor at Homi Bhabha Cancer Center, Hospital and Research Center, Vizag.
Am I audible?
Yes, yes.
Yeah, thank you. Just a second. Are the slides visible?
Visible.
Yeah. So, Pradeep Vendrapati, and today I will be speaking on the recently published abstract, which is neoadjuvant chemotherapy alone versus chemoradiation, followed by sleeve resection for locally advanced non-small cell lung cancer. So, coming to the background, the treatment of patients with locally advanced NSCLC is complex and requires the expertise of a MDT thoracic oncology team. So we know that neoadjuvant platinum-based chemotherapy followed by surgery has been found to improve survival in these patients. Neoadjuvant chemoradiation also improves nodal clearance and is a strong rationale for adding radiation to the neoadjuvant treatment approach. Although improved survival with neoadjuvant chemoradiation followed by resection has not been shown in phase 3 trials to date, we should understand that these studies have been limited by slow accrual rates, patient selection, outdated radiation techniques, and detrimental interruptions in therapy. And also there are high mortality rates with the pneumonectomy. So there is an evidence gap in the risk-benefit ratio of this approach, and it is not well defined in patients who are requiring sleeve resection only. So as we know, sleeve resection, only a part of the airway is removed and the rest of the airway is rejoined along with the rest of the lobes, so that we can preserve as much lung as possible while getting rid of the cancer. So the objective of the study was to compare the short and long-term outcomes of neoadjuvant chemotherapy alone versus chemoradiation followed by sleeve lung resection. So the study design was retrospective. The patient pool was from the National Cancer Database in the United States. Locally advanced NSCLC patients who underwent sleeve lung resection between 2006 and 2017 and received neoadjuvant therapy were included in the study. There were two groups. They were divided into two groups. One is the chemotherapy group and the other is the chemoradiation group. And the outcomes of interest were the 30-day mortality, 90-day mortality, and the overall survival. So to minimize confounding by indication, the propensity score adjustment, logistic regression, Kaplan-Meier survival analysis, and Cox hazard model were used to identify associations. So coming to the results, there were in total 176 patients who were analyzed, and out of that 92 patients were in the chemotherapy group and 84 in the neoadjuvant chemoradiation group. All the patients' demographic characteristics and the tumor characteristics were well balanced. And the 30-day mortality and the overall survival was similar in both the groups, but there was significant difference in the 90-day mortality, which was higher in the chemoradiation group. So even on multivariable analysis, neoadjuvant chemoradiation was associated with a higher 90-day mortality, and it was not associated with any overall survival benefit. So it was concluded that in locally advanced resectable NSCLC who are requiring a sleeve lung resection, neoadjuvant chemoradiation was associated with a 5-fold increase in 90-day mortality without an overall survival benefit for neoadjuvant chemotherapy alone. So coming to the opinion on the study, so we know that previous studies which examined the role of neoadjuvant chemoradiation have shown a trend towards improved outcomes, but there is no concrete evidence in terms of improvement in survival. Also, all these studies which have shown some trend had a heterogeneous mix of patients, and they underwent pneumonectomies also. So this is a retrospective study which looked back at patterns in the National Cancer Database and compared the outcomes of two different groups, that is the NACT and the neoadjuvant chemoradiation, only in patients who underwent sleeve resection. So the important take home from the study is that the addition of radiation therapy did not improve OS outcomes, and more patients in the chemoradiation group had died 90 days after surgery. But it is reasonable to think that adding radiotherapy has increased the side effects, and that's why the outcomes were poor. But the study did not examine any quality of life or patient-reported outcome data to confirm if this is actually true. So also this is a retrospective analysis, and the best evidence would be to test the two options head-to-head in a clinical trial. Also, we don't have the nodal status, margin status, and the PATH-CR rates in the two groups. But still, this research does provide new data suggesting that chemotherapy alone is preferable over chemoradiation before sleeve resection surgery due to similar survival outcome and potential for reduced side effects. But we have to understand that with the immunotherapy now taking over the neoadjuvant clinical trial design, so such a study may not be even conducted. But this is important for our country, where obviously immunotherapy, the affordability of immunotherapy comes into question. And if we have to choose between NACT and NACRT for sleeve resection, probably NACT might be a better option. Thank you.
Thank you. Technical glitch is, so we request Dr. Narmada for her next presentation, long-term survival of operable stage 3A.
Yeah. Hi, good morning all. I think I'm audible right now.
Yeah, you're audible, Narmada.
Okay. So sorry for the delay. So I would like to start with my presentation slides, please. Yeah, what my previous speakers have told, the stage 3 NSCLC it's a heterogeneous group of tumors with varying prognosis and treatment options, and the patients with stage 3A with the clinically N2 nodal spread would have a 5-year survival somewhere close to 35 to 40%, which will drop down to less than 10% if it's a bulky multiple mediastinal nodes. So there's a desperate need for this subset to have a good survival outcomes. Next slide. And coming on to the rationale to include neoadjuvant immunotherapy. And so the PD1 inhibition requires the antigen presentation to the tumor cells, to the host T cells. So in case of neoadjuvant setting where there is a large antigen burden in the whole tumor, so which will invariably produce a stronger anti-tumor T cell immunity. And these are the various studies where either immunotherapy or immuno plus chemotherapy has been tried in the neoadjuvant setting. And interestingly, the endpoint, it's projecting the pathological response, which might be a good surrogate as the overall survival. Next slide. So this is the review of the study I'm going to go through. So it's about the NADAM study, which is the long-term survival in operable stage 3A non-small cell lung cancer, which was treated with neoadjuvant nivolumab with chemotherapy. So the hypothesis was that the neoadjuvant chemoimmunotherapy could increase the proportion of patients who could achieve a complete pathological response, and that this approach would increase the number of patients that can ultimately be cured. And it was a very small study, a phase 2 single arm done between 2017 to 18 in Spain. And it had only 46 patients, and it was the first study of this kind to include immunotherapy along with neoadjuvant in a resectable tumor. Next slide. So the inclusion criteria were all straightforward, histologically or cytologically documented stage 3A. And if it was a suspected N2, it should have been proved either by mediastinal staging. And it was all deemed surgically resectable before the patient was taken up for the study with a good performance status of 0 or 1. And in patients with the known mutations were excluded from the study, along with the other factors for the classical contraindications to include the immunotherapy. And the primary endpoint was the PFS at the end of 3 years. The intention to treat analysis would include all patients receiving neoadjuvant treatment. And the per protocol analysis would include who had undergone surgery and who has at least received one cycle of adjuvant nivolumab. And the other endpoint included in the secondary endpoint was the overall survival response, the surgical outcomes, and the safety profile. Next slide. So the baseline characters, to be short, almost 75% of patients were all males, with distribution of adenocarcinoma of 57% and squamous of 35%. And the majority of the patients had actually N2 disease. Almost 20% had single station, and 54 patients had multinodal disease in the N2. And others include anywhere from T1 to T4 disease. Next slide. So the protocol was like after the patient has been staged with the biopsy from the primary mediastinal staging along with the PET scan and brain imaging, patient was taken up for the neoadjuvant treatment, which included 3 cycles of paclitaxel carboplatin with nivolumab, which was given 3 weeks once for about 3 cycles. But the dose of nivolumab in this study was used was 360 milligram flat dosing. It was not based on the per kg weight. So when I look to the rationale for using this, they have mentioned the 360 milligram, which is given every 3 weeks. It is almost the same average drug exposure, the pharmacokinetics, as compared to the 3 mg per kg, which is given every 2 weeks. And this was followed up by imaging and the surgical resection. Almost most of the patients had undergone a lobectomy with a complete nodal dissection, which was all R0, almost 100%. And this was followed after 3 to 4 weeks. The patient had received adjuvant nivolumab for almost a year. So here they have used 240 milligram every 2 weeks for 4 months, which was followed by a monthly dose of 480 milligram. Next. Yeah, so and also the other details like the TMB, PDL1 scoring, and multiplex immunofluorescence was all collected from the FFP samples. And almost 100% of the patients has completed the neoadjuvant treatment. And based upon the radiological finding, about 76% had an overall response rate. And this constituted mostly partial response of about 72%. And when about 41% of patients, almost 90%, underwent surgical resection. And coming to the pathological response, so the response was classified basically into a complete pathological response, or a major pathological response, or incomplete pathological response. So here, if it is complete, there was no viable tumor. If it is less than 10% viable disease, it constituted the major pathological response. And the important thing is that about 83% actually had achieved a major pathological response. Among them, almost 63% had a complete pathological response. And followed by almost 90% were received adjuvant nivolumab for a year. The average duration of exposure was 10 months. Next slide. So the toxicity profile would be like any other regimens where chemo was combined with immunotherapy. There was no additional side effects noted, and there was no treatment delay or surgical complications, or any death noted because of adding nivolumab. And
Narmada,
there was some...
sorry to interrupt. Will you conclude in the next 1 minute?
Yeah, sure. Next, please. Yeah, so coming to the results, so this was the highlight. So around at 36 months and 42 months, the PFS still remained to be somewhere in terms of like 80% and above. And even the overall survival at 3.5 years were close to 87%, which looks very remarkable. So it's a small study with a small patient population group. Next slide. So, and the PFS in the OS, when we look into the correlation with the pathological response, those who achieved complete pathological response obviously had a higher PFS. And also those who had a major pathological response were also having a very good outcomes. Next slide. But when we look into the biomarker, actually, it was not very much correlating either with the PD-L1 or with the tumor mutational burden. We don't know which subset would actually benefit from this very good response. And also patients with other specific mutations would not have a very good PFS, which we know through the previous studies as well. Next slide. So coming to the conclusion, the efficacy of neoadjuvant chemo with immunotherapy with nivolumab in the resectable stage 3 showed a very good safety profile with higher pathological response and promising PFS and likely OS benefit. But there are some limitations. It is a small study with a single arm. We don't have a good comparator. But compared to the historical studies, it looks very promising. But there is no effective biomarker which could predict the response. And the cutoff of TPS was not convincing. And the translation of pathological response to making up to the survival outcomes, and the significance of the major pathological response, and the additional benefit for continuing 1 year of nivolumab. These are some concerns which needs to be addressed in the ongoing NADAM-2 study. Thank you.
Yeah, thank you, and thank all the speakers for keeping up the time. And we are sorry that Narmada couldn't do it in the first chance. It's happy to see that immunotherapy is coming up in the neoadjuvant setting, and almost all the trials have shown or at least achieved the primary endpoint. And the major pathological response or a pathological CR, we don't know whether this will be translated into survival. So thank you all, and back to the organizers.
Thank you, sir, for chairing the session. We now move on to the panel discussion. I would like to invite the moderator for this panel discussion, Dr. Chirag Desai, consultant medical oncologist from Ahmedabad, to start the panel discussion and invite the panelists.
Thank you very much, organizers, for involving in this wonderful session. I hope I am audible and my slides are visible. I have been instructed by the organizer to restrict to 20 to 22 minutes because of the delay. So I request all my panelists to give the clear and crisp answer. We want to cover a few things. I mean, immunotherapy in neoadjuvant therapy is a new thing. And before we discuss any new thing, I think let us re-examine our roots, that from where we are coming and where we are going. So my panelists are Dr. Anuj Gupta, Dr. Nizamuddin, Dr. Yashwant, Dr. Hollis, and Dr. Aisha, and I hope that all of them are present in the panel right now.
Yes, sir.
Dr. Nizamuddin is a surgical oncologist, and all other are medical oncologists. Today's discussion will quickly look at the concept of neoadjuvant therapy in NSCLC. We will also have a good discussion on neoadjuvant chemotherapy versus immunotherapy, as well as a couple of slides on neoadjuvant radiation. And these are the various trials that we are going to discuss in today's presentation. So, where are we starting? We know that lung cancer is a bad disease. We very rarely ever see that in stage 1A, but if we do that, the survival is around 80%. If we go down to stage 3A, the survival is less than 40%. 40% also, I think, overstatement. And how do we increase the survival? By giving chemotherapy before or after surgery, and that improves the survival by about 5%. So there is a large room for improvement by doing anything that is possible. And we have done a few things, and we will do what we have done. So my question will start with Dr. Nizamuddin, that which are the patients that in your practice you will consider for adjuvant chemotherapy?
Any patient with tumor, any patient with limited mediastinal nodes, that is a single station mediastinal node detected with the invasive mediastinal evaluation, or any resectable, any doubtful resectability where we think that downstaging will be beneficial.
Dr. Nizamuddin, my question is for adjuvant and not neoadjuvant right now.
Okay, adjuvant.
Yeah.
Yeah. Any patient with tumor size more than 4 centimeter after surgical resection, or any node positive patient, any mediastinal or hilar node positive patients, usually we prefer for adjuvant chemotherapy.
Good. There is little controversy, little contradiction when we will give rather adjuvant chemotherapy. So Anuj, we can see in some of the slides that adjuvant atezolizumab has already been made its way in NCCN guidelines. So quickly, if reflected in one sentence, that which are the patients where you will consider adjuvant atezolizumab?
Okay. Sir, the patient who are having a tumor burden and N2 disease, which are having a bulky disease, bulky nodal disease, in such patient, we would like to give adjuvant atezolizumab.
Sir, any stage 2A to 3A and PDL1 more than 1%. That is what is actually was for atezolizumab.
Exactly. Yeah. So are you convinced? That was Dr. Yashwant, right?
Ashay, sir.
Ashay, okay. Yeah. So, Ashay, are you convinced with atezolizumab data as adjuvant therapy?
No, sir. But that is what is actually NCCN recommends.
Exactly.
But
Exactly.
there is not actually,
Yeah.
if you look at the separation of the curves, is not great really when you look at the adjuvant chemotherapy versus atezolizumab actually.
Right. So, Hollis, Dr. Nizamuddin just started discussing about candidates for neoadjuvant chemotherapy. So, what is your take on that? Which are the patients who should be given neoadjuvant chemotherapy rather than adjuvant chemotherapy?
Sir, N2 disease is what? And I think poor surgical candidates, because they might not tolerate adjuvant chemotherapy as good as neoadjuvant chemotherapy.
So these are the patients, right? Stage 3A, T4 and N01, where either you will give concurrent chemoradiation or chemotherapy followed by surgery. And if there is non-invasive T3 with N2 nodes, either definitive chemoradiation or induction chemotherapy.
Yes, sir. N1 I feel is a gray zone, but N2 definitely I'll prefer induction chemotherapy rather than chemo-RT. It's what I feel. If the surgeon is confident that it is going to resect.
Right. The question is to Dr. Nizamuddin. Will you be happy with chemoradiation, or you will just want to go for chemotherapy before you take the patient for surgery?
I'll be happy with the neoadjuvant chemotherapy rather than chemoradiation.
Right. And can you tell me what are the possible reasons for that?
There is an increased chance of surgical morbidity as well as the presence of pneumonitis from neoadjuvant chemoradiation is what is known.
So, Dr. Yashwant, there are some trials, and even in NCCN, concurrent chemoradiation or it has been written as the treatment before surgery. So, what is your take on that? Will you ever give concurrent chemoradiation? We are coming to the trial that has been presented, but what is the general impression? Dr. Yashwant is there?
Sorry,
Yeah.
can you please repeat the question?
So, will you give neoadjuvant chemoradiation to any patient? And what is your take on the available data on that?
Sir, for neoadjuvant chemoradiation, I will not give. I will go for in such patient in Penco's tumor only. We generally go for neoadjuvant chemoradiation. Other case in T2 single station when surgeon are not confident, I will give NSCT only.
Great. So I had the opportunity of discussing the same issue with multiple people within as well as outside the country. And even though it has been mentioned in literature as well as in NCCN guideline, concurrent chemoradiation as neoadjuvant therapy is hardly ever practiced in the real life clinical practice. So, Dr. Yashwant, to you only, why will you give any treatment before surgery if the patient is resectable? Why neoadjuvant and why not only adjuvant? Some reasons have been mentioned over here, but if you can elaborate on that.
In many cases, we discuss such cases in tumor board. So, sometime our surgeons are not confident about in single station disease or due to dates and other thing also. So, such patient I consider for giving chemo.
Hollis, any other addition to what Dr. Yashwant already said?
Sir, I feel patient fitness. If the patient is able to tolerate it, definitely I'll give a chemotherapy prior to surgery rather than chemotherapy after surgery. There are other things that we can always consider. The reason why NSCT is given other biologies as well that target the micrometastasis early. But I feel the most important is the performance status, because looking at these curves, we know that neoadjuvant or adjuvant, the OS is the same.
Right. So, if you look at the table on the bottom of this slide, that received full dose of chemotherapy was 78 versus 63%, neoadjuvant versus adjuvant, all cycles of chemotherapy 91 versus 78%, and grade 3 or higher toxicity was higher in adjuvant chemotherapy. But if you look at the DFS and OS, it is nearly superimposable. There is hardly any difference. So we should give either adjuvant or neoadjuvant chemotherapy. And now what we are going to discuss next is how we can add on what we already achieved with adjuvant or neoadjuvant chemotherapy. And we just heard that neoadjuvant chemoradiation is not popular, and that came out of this trial as well, even though, as the presenter rightly said, that this was about the patient who required sleeve resection, were likely having a higher tumor volume. It was a retrospective study, and it showed that 90-day mortality was higher and the survival was not different. And I think we have already discussed in our group, so we are not discussing any further on this particular trial. So, what about neoadjuvant immunotherapy? And I want Ashay to answer. What is the rationale of giving immunotherapy ahead of surgery?
Yeah, so basically, as we always say, so whenever we give chemotherapy, there may be down regulation to the T cells or Treg cells. That also happens, and that is more likely to have a micrometastasis in the future, post-operatively. So by giving immunotherapy, maybe the hypothesis was, you basically, what you can say, enhance T, so that, the effect is much better. And other thing is that even giving chemotherapy along with also means, because the thing is that if you look at it, the immunotherapy alone hasn't that impact if you actually see the immunotherapy combined with the chemotherapy. So if that is done, basically, that exposes the tumor antigens to the immunotherapy and maybe better upregulation of the T cell immunity. So I think that is something which is a rational. But only thing is that at the end of the day, PATH-CR, whether it will transmit to the overall survival or PFS, that is what is most important thing.
Right. So there is good theoretical background for offering immunotherapy ahead of surgery. because large burden of the tumor will activate the immunity more as compared to that we can achieve after surgery. And that has been seen in the animal models by improving the survival. So we will examine next maybe 10-15 minutes whether it happens in the clinical trials as well or not. So there are multiple trials which have already been either presented or published. Immunotherapy, monotherapy as neoadjuvant therapy, 6 trials, phases 1B and 2. Combination immunotherapy, there are 2 trials, phase 2 trials. Combination immunotherapy and chemotherapy, we have maximum data, but a lot of things are not yet available in the public domain. 10 trials, phases 2 and 3. Only 1 trial is available right now for discussion. And combination of immunotherapy and radiotherapy, 3 trials. We will be discussing one of these trials. And these are phase 2 trials. So, intention of any neoadjuvant or adjuvant therapy is cure. And the gold standard endpoint is improvement in the overall survival. But the surrogate is improvement in the disease-free survival in most of the trials across the tumor types. In neoadjuvant chemotherapy, in some of the diseases, it is PCR, while in neoadjuvant immunotherapy, it is major pathological response. And the question is to Anuj, whether you agree with this endpoint.
Okay, for neoadjuvant immunotherapy, in most of the trials, major pathological response has been taken as an endpoint, because definitely for a curative setting, we cannot follow the patient for a long to wait for such an important decision making. Major pathological response is any response when the viable tumor size is residual tumor percent is less than 10%. So in many other trials before, also in other organ-wise DMGs, we have seen that the pathological response, which is not a complete response, have not turned out into the overall survival benefit. So at this point, we are although taking this major pathological response as a surrogate marker, but definitely it has to be validated and it has to be established as a standard. And at simultaneously, we should also look for the other endpoints which can better define across all the trials.
So, Dr. Yashwant, are you happy with this table that HR for death, this is the indirect mirror for survival itself? If the percentage of residual viable tumor is 1 to 10%, that is major pathological response. If we call it 1, with any higher amount of the residual disease, it is exponentially increasing. So it is best to induce PCR, but MPR is also a good surrogate marker. Do you agree with that?
As Dr. Anuj said, it has to be validated in longer trials. But I'm not happy with this. Based on that, those who because patient who are not getting, as per this data, patient who are not getting good response, they are doing bad. So for such patients,
yeah, okay, thank you, Dr. Nizamuddin. If you have the patient who is T2N1 operable patient, and you know that the patient is definitely going to require adjuvant chemotherapy, but will you submit that patient to neoadjuvant immunotherapy? And if so, it will be based on what endpoint that you see in the clinical trial? Is it MPR, PCR, DFS, or overall survival? What will be your standard reason for accepting that trial in your practice?
So the results coming out of the neoadjuvant immunotherapy are very promising, with a very high MPR and PCR as well. But the long-term results are awaited. Hopefully, they will also result overall survival as well as progression-free survival. Till the data gets mature and more results are available, we cannot accept neoadjuvant immunotherapy as a standard in our practice. As of now, if a patient is coming with a T2N1 lung cancer, he is very well a candidate for upfront surgery followed by adjuvant chemotherapy. So, at present, in clinical practice, for a patient with a T2N1 disease, upfront surgery will remain the standard of care, followed by adjuvant chemotherapy.
So, Great. So with upfront surgery and adjuvant chemotherapy, we can improve the survival from 50% to 55%. And we will try to figure out in the next few slides whether we can improve it from 55% to 60% or not. Right. So for that minimum data that I will want to look at is MPR and DFS. I will not change my practice only looking at MPR. I will also want to look at DFS, and I don't want any discussion on this particular point. Everyone will have a chance to comment towards the end of the discussion, and maybe you can point as well. So, immunotherapy, monotherapy, we already heard that there is phase 1 trial of pembrolizumab, MK3475, 223, and I think a lot of water has flown in Ganges, so we don't need to waste a lot of time on this particular study. It was stage 1 and 2 NSCLC, and it only showed that it is feasible, and almost 40% or 44% of the patients were having a major pathological response. It was irrespective of the study based on very small number of patients. So it only says that the drug works, and it works in some patients. We don't know in which patient does it work. So then there are number of phase 1 and 2 studies exploring various neoadjuvant PD-L1 or PD-L1 monotherapy, giving the patient nivolumab or sintilimab or atezolizumab, one of these drug, and MK3475 is right here. And endpoint in this patient is safety, feasibility, MPR, R0 resection rate, and so on and so forth. If you look at the combination of immunotherapy, there are 2 studies. Each of them is looking at Nivo-EP combination. And if you look at the result of some of these studies quickly, small number of patients in each of these study, and various proportion of the patient having squamous cell carcinoma, a different distribution between stage 1, 2 as well as stage 3 patients. If you look at the percentage of the patient taken for surgery, in each of the immuno-oncology monotherapy, it is around 90 to 100%. While for dual checkpoint inhibition, it is 67% in this trial, 81% in this trial. Remember that, that's important. If you look at the PCR as well as MPR, just focus on MPR, it is 30 to 40% on immunotherapy as monotherapy. And PCR is around 10%, while here the PCR is 33%. In spite of having fewer patients taken for surgery, the PCR is exciting. So we need to figure out what is the reason and how we can overcome this reason. How can we improve the resection rate in these patients? But we are not going to discuss that because that is not the main point that we are discussing right now. Biomarker correlation is poor in most of the studies. With PD-L1, that is correlation seen in a couple of them, and TMB, it is seen only in one of them. So we don't know which are the biomarkers. So the question is to Hollis, theoretically, can addition of chemotherapy improve the efficacy of immunotherapy?
Yes, so theoretically, it is going to increase the effect of immunotherapy. You have a bulky disease at baseline. Immunotherapy is going to expose the antigens. There's going to be more of tails coming in. So theoretically, yes, adding immunotherapy to chemotherapy is beneficial.
So we'll examine in the next few slides whether it actually happens or not. And we have the Nadeem Shravan, we have Nadeem trial. We will listen to what Shravan says little later. But what Nadeem says, Narmada excellently discussed that. And if you look at the MPR, if you remember the previous slides, the MPR was around 30-40%, while in this particular trial of 46 patients, small trial, MPR is excellent, 83%, and PCR also is excellent, 63%. So, Dr. Nizamuddin, if you had this trial as a phase 3 result, will you accept and submit neoadjuvant immunochemotherapy to practically all the patients?
So this trial is it's a small trial. It's a phase 2 trial, but the results are very promising. Actually, we have to admit that the MPR and PCR rates are very promising, as well as the 3-year overall survival is intention with the intentional treaty analysis. It is around 82%, and the per protocol analysis crossed 90%. And another main point about this trial is almost all of the patients were in the stage 3. Majority of the patients were in the stage 3.
That's correct.
And majority of this stage 3 patients, stage 3, multiple mediastinal node positive. So overall, looking this trial shows a very good promise, but it's a very small trial and it's a phase 2 trial. I think we have to wait for other phase 3 trials to show up the results.
Right. So Nadim Shravan is the musical melodies. They are the musicians. This is what Nadim says, and this is what now Shravan says. He is telling something different. So there is a phase 3 clinical trial.
Sir,
816.
sorry to interrupt, sir. We've run out
Yeah.
of time, so request you to conclude the panel discussion quickly.
So, okay, so let me quickly go through Nadim, this Checkmate 816 trial. The primary endpoint was PCR and not MPR, and that was seen in PCR was seen in 24% of the combination patient and 36.9%. This is opposite as compared to Nadim trial. So, Ashay, any comment on that? Why should there be such a vast difference?
So basically, sir, I always feel that whenever we are using immunotherapy, even neoadjuvant adjuvant setting, we are struggling with the biomarkers, basically. Yeah. So what exactly the biomarkers? Even if you look at the Nadim trial, and you look at even the CPS, basically, more than, I mean, they try to put a various cutoff, and even less than 25%, they are more response rates. Even the PDL1, which is, if you look at even the pembrolizumab trial, in the standard, we use pembrolizumab as an upfront marker, PDL1, but there was no PDL1 correlation was also there. So if you really look at, I don't think we have understood a biology adequately enough to give neoadjuvant therapy in the, what you can say, neoadjuvant setting. But having said that, I think the chemotherapy plays a vital role when combined with the immunotherapy setting.
So, Dr. Nizamuddin, this trial shows that the surgical outcome is not much different. Do you agree with that?
Yes, here the PCR rate is not as much as the Nadim trial. PCR rate has come down to 24% in the neoadjuvant immunochemotherapy arm as compared to 63% in the Nadim trial. So this trial is more of a real world scenario. For the long term outcome, the Checkmate 816 trial as well as other phase 3 trials to reach.
So at present, yeah, agreed. So at present, we have multiple phase 3 clinical trial. We have the early trial of only 816 study, and that is not same as what Nadim was telling. So let us wait for the other phase 3 clinical trials, and that will be very important to look at. And what about immunotherapy and radiation? Maybe in 1 minute, Dr. Hollis can tell about that.
Sir, it is an early trial. I am not very sure whether it will stand the long run, because Durva is definitely better in an adjuvant setup post, but maybe in the neoadjuvant setup, maintenance, not very sure whether it will help.
Right. So this is my concluding slide. Look at the second point. Preoperative PD-1 inhibitor is the safe, feasible, and associated with MPR of 20 to 45%, and that can be improved by addition of chemotherapy. And we don't have any more data in addition to this particular data. So future will tell us about how we can incorporate immunotherapy in the neoadjuvant trial. Thank you very much from my entire group. And let us have a quick half-minute comments from each of the panelists. Dr. Anuj?
Okay, thank you, sir. I think the data from the available presently are quite encouraging, and it will clear definitely that this immunotherapy will have a neoadjuvant role in the coming era. But again, we need to look at the proper endpoints, and we need to get another important question which has to be asked is whether in the adjuvant setting what type of chemotherapy or immunotherapy is required. So there are certain questions which have to be answered, but still this is a promising aspect of the lung cancer.
Yeah. Dr. Nizamuddin, quick comment.
Yes, the immunotherapy and immunotherapy seems promising, but one thing noticeable is the absence of an upfront surgery on any of these trials. If you look at the Nadim trial, they are given adjuvant immunotherapy as well. So it becomes difficult to tell whether the neoadjuvant immunotherapy or adjuvant immunotherapy, which has a greater impact on survival based on these trials. So there is always a possibility of upfront surgery in early lung cancer followed by actual immunotherapy, which is not tested in any of the.
Right. There are trials in that extent as well. Dr. Yashwant, quick comment, half a minute.
Sir, immunotherapy as any well established in metastatic setting. Seeing this data, I am very much optimistic that definitely surgeon's perspective will be changed.
Let's hope so. Dr. Hollis?
Sir, definitely 2-3 things. First is good biomarkers. We need to determine whether PDL1 or TMB. My preference would be an N2 disease. An interim endpoint, maybe looking at the CheckMate trial, radiological response is discordant to the MPR. So maybe MPR, but not the radiological response. If my surgeon is not sure of the radiological response, he might not operate. He might send it for radiation. And definitely adjuvant, as the surgeon has pointed out, adjuvant immunotherapy, the role of adjuvant immunotherapy in that. So these 3 things need to be sorted out. Then I'll be convinced whether immuno is going to work or not.
Dr. Akshay?
So I agree with, see, the thing is that if the surgeon said is upfront operable and can operate, I will not give a neoadjuvant chemoimmunotherapy at this particular juncture. Only patients where neoadjuvant has been advised, maybe dates, maybe because of the performance status where they wanted to optimize the patient before surgery, these are the patients. And as Holly has pointed out, maybe N2 disease where I will give. But as of now, I will rely upon maybe the adjuvant maintenance immunotherapy at this juncture.
So at present, we have only one phase 3 clinical trial. At least 3 or 4 of them are ongoing, and let us look at them. If these 3-4 trials are able to convince us, hopefully in the next year, next December, we will discuss that we will want or not want to give immunotherapy all the patients in adjuvant. With that, so thank you very much for involving us in this wonderful discussion. Thanks to all the panelists.
Thank you, sir. Thank you to all the speakers and the chairpersons of this session. For the next session, I would like to invite the session coordinator, Dr. Akhil Kapoor, consultant medical oncologist at TMC Varanasi. Over to you, Akhil.
Thank you, ma'am. So we are into the third session today. The third session is about the first line immunotherapy options, and the chairpersons for this session are Dr. Jatin Sareen. He is the director of the oncology at IV Hospital Mohali. Second chairperson is Dr. Sandeep Jasuja sir. He is the medical superintendent, State Cancer Institute and HOD Department of Medical Oncology at SMS Jaipur.
Hello.
Yeah.
Hello. Good morning, everyone. And let me thanks our organizer for giving the opportunity to be chairing this session. And now, after a wonderful session of neoadjuvant immunotherapy in lung cancer, now we're moving on to the first line therapy. As we know that any treatment, any drugs which is approved for the treatment of oncology comes in later stages of the disease in palliative setup or in third or fourth line setting. And if something is happening and giving a new good results, then it comes to the first line and it becomes the standard of care therapies. For this purpose, now we know the immunotherapy is very good, doing wonders in all kind of oncology. And now we, but what is the role of the first line chemotherapy? We will see in our next sessions. And for this purpose, I would like to invite our first speaker, Dr. Kripa Shankar, consultant medical oncologist, NCR Contour Center, Coimbatore. And he will be enlightening us on the first line nivolumab plus EP plus 2 cycle of chemotherapy versus chemotherapy alone. In patient with advanced NSCLC cancer, 2-year update from CheckMate 9LA. Dr. Kripa Shankar, over to you.
Thank you very much for those kind words. I'll just share my screen and we'll get started. So a very good Sunday morning to all of you. And before I begin at the outset, I'd like to take this opportunity to congratulate the organizers and also thank them for the opportunity. So I'm going to be quickly going through the 2-year update of the CheckMate 9LA, which looked at a combination of IO plus IO, or as in Tamil we would call it the IAO combination. Was it really IAO or was it like a IO for this combination, especially in combination with chemotherapy? So let's look at the background as to why this was done. We all know about the complementary mechanism of action of the PDL1 with the CTLA4 as well. So that, and we've seen that from melanoma, RCC and non-small cell lung cancer as well. So the earlier report showed that there was an improvement in the response rates, the PFS, and overall survival as well. But what about the duration? I mean, like of response as well, and also was it still continued even at 2 years? That's what the current update is going to focus on. So we know that the benefit was seen irrespective of the PD-L1 levels and the histology, and it's also already an FDA-approved option as well. So what I'm going to be showing you right now is also the data on the WCLC update, which looked at, the role of this combination in patients with brain metastasis as well. So, as you can clearly see here, there were about 50 patients who had brain metastasis were included in the study as well. And again, this was a randomization between an IO plus chemo versus only chemotherapy for 4 cycles, followed by maintenance chemo. And the primary endpoint again here being OS. So let's look at the patients with baseline brain metastasis. Well, they were all evenly matched as far as the patient characteristics were concerned. Well, but clearly, as you can see here, as far as the response rates and the intracranial response rates were concerned, and also as far as progression in the CNS was concerned, well, clearly superior with the combination of IO plus chemotherapy as opposed to only chemotherapy alone. And this was the update on the 2-year update on the overall survival. Again, clearly this was across the board in the entire intention to treat population, 16 versus 11 months, absolute benefit of around 5 months. And even if you dissect both the histologies, the non-squamous and the squamous histology together as well, the magnitude of benefit was still preserved. And if you look at this forest plot and the subgroup analysis, again, across the board, across most of the subgroups, you can see that the combination actually did much better, albeit irrespective of the age, the performance status, the smoking status, and with the presence of CNS metastasis as well. And looking at the 2-year update on the progression-free survival assessment, because this has always been a caveat. Whenever you talk about immunotherapy, we always talk about there not being a very clinically significant improvement in PFS, but you always get to see an overall survival benefit because our immunotherapy does take a longer time to actually bring about its action. But still, despite all that, you see almost a 2-month improvement in the PFS, an absolute improvement of 2 months, 7 versus 5 months. And again, the duration of response was also, and this is probably the best part about immunotherapy. We know that somebody who responds is going to respond for a longer duration. And that's clearly evident here, 13 versus 5.5 months. Clearly, again, in favor of the combination. And this was also seen irrespective of the PD-L1 expression. And I think that's a major win for this trial because, usually when you talk about the magnitude of benefit, it comes down in patients who have less than 1% PD-L1 expression. But what this trial actually did show is that with the combination, even in those patients who have less than 1% PD-L1 expression, the magnitude of benefit actually remained the same. And again, as I had highlighted earlier, the systemic efficacy outcomes were absolutely similar, and even in patients who had baseline brain metastasis. And the intracranial response rates were actually quite impressive to the tune of around 40% and 20% as opposed to 20% with only chemotherapy. And again, number of patients who actually progressed in the CNS after this combination was much lesser as opposed to patients who had only received chemotherapy. So moving on to the safety data again, the treatment discontinuation rates, albeit slightly higher with the combination arm, but nevertheless, the toxicity was pretty manageable and in tune with what we had seen from the earlier Checkmate 227 data as well, which looked at only the combination of Nivo-IP without chemotherapy. And most of the adverse events usually happen, from cycle 1 to 4, and that's within the first couple of months. That's probably got to do a lot with the addition of the CTLA-4 as well. And we know that we're going to use chemotherapy only for the first 2 cycles. So I think that's another reason as to why you get to see these toxicities much more in the first couple of months. And the good thing about it is this was only an exploratory subgroup post hoc analysis. And even in those patients who actually ended up discontinuing because of any treatment-related adverse events, there was still a magnitude of benefit seen in those patients as well. I think that's probably very key. And to conclude, I would probably say the 2-year overall survival data, to put things in perspective, 38 versus 26%, more than 10% improvement in absolute improvement in overall survival at the end of 2 years. And this was irrespective of the histology, irrespective of CNS metastasis, and irrespective of the PD-L1 expression levels. And a pretty manageable safety profile, as I had shared earlier. And again, like I said earlier, this was the WCLC update from the Checkmate 9LA. And the efficacy was maintained in patients with brain metastasis and also in patients who had discontinued because of treatment-related adverse events. So this is, you're spoiled for choices in this current era. Look at all the combinations that are absolutely approved. So how does the Checkmate 9LA hold up against the others? Well, even in patients who have a very high PD-L1 expression, monotherapy probably alone is good enough based on the pembro, atezo, and cemiplimab data. But what about patients who have PD-L1 negative disease? And I think this is probably one place where the Checkmate 9LA scores over all the other combinations, because you see that here that the magnitude of benefit is maintained even in that subset, as in the PD-L1 negative subset. So, and this probably I'm going to end with this algorithm. This is what is recommended across the board across other guidelines and recommendations as well. So very clearly what you can see is in the PD-L1 less than 1%, PD-L1 inhibitors with the CTLA4 and chemotherapy is here to stay. So with that, I'll conclude and say thank you all for your patient listening.
Thank you, Kripashankar. Very crisp presentation, and this was a very interesting data, irrespective of histology, irrespective of the PD-L1 status, which is one of the most robust biomarker we still have for determining chemotherapy. Now, the next speaker is Dr. M.V. Chandrakant. He's a consultant medical oncologist at Narayana Super Specialty Hospital, Kolkata. And he will be speaking on the outcomes of anti-PD-L1 therapy in combination with chemotherapy versus IO alone in the treatment of advanced non-small cell cancer with the PD-L1 score less than 50%, 1 to 49%. What is the FDA pool analysis? Over to you, Dr. Chandrakant.
Thanks, Dr. Jatin, for the introduction, and I would thank the organizers for the opportunity. Well, this is a unique FDA-based pooled analysis where they have specifically looked at 1 to 49% subset. So, as Dr. Krupa was just mentioning in the previous presentation, this is what we have. We practice in day-to-day. So if PD-L1 is more than 50%, we have pembro mono, atezo mono, which is available with us. And if the PD-L1 is less than 50%, we have chemo pembro, chemo atezo in adeno. We have ABCP, we have nivo EP and nivo EP chemo. So this is the options which are available to us in the present day. So the usual comparison in majority of clinical trials is IO versus chemo or IO chemo versus chemo. So the comparator arm is usually chemotherapy, which is a weaker arm. Whereas in this FDA pooled analysis, which we have IO chemo versus IO. So specifically addressing the issue of chemo IO combination versus IO monotherapy in the specific subset of PD-L1 1 to 49%. So well, this is the
sorry to interrupt, Dr. Chandrakant. Your slides are not moving and they are not visible.
Okay, then can I ask the organizers? I've already shared the slides. Okay. Okay, so I think now it's visible. So, well, so I was addressing to the keynote 042 data, where they specifically looked into overall survival as an endpoint in those patients who had PD-L1 more than 50 versus 1 to 49. They compared pembrolizumab monotherapy versus chemotherapy. In this, if you look into overall survival as an endpoint, the hazard ratio was 0.69 with a significant p-value. Whereas if you look into PD-L1 1 to 49, here the hazard ratio is 0.92 and it is not significant, it is crossing unity. Therefore, in the subset where it is 1 to 49, pembro monotherapy is not a great option. Next slide. So this is basically a FDA-based pooled analysis, and we do pooled analysis. It is a statistical technique for combining the results of multiple clinical trials. It is not individual patient data. It is the results of multiple clinical trials. And it is useful when the results of individual studies do not give a firm conclusion. Next slide. So in this
pooled analysis, they included 8 randomized controlled trials, including 2 randomized controlled trials having Pembro mono and Nivo ipi trials, which we just discussed before. And this included both PD-1 and PD-L1 inhibitors. Next slide. So they basically tested PD-L1 only on tumor cells. They did not include PD-L1 on immune cells. And this was a comparison of IO chemo versus IO. And they looked into endpoints of progression-free survival and overall survival. Next slide. So these were the results. They included 2,100 patients. They specifically addressed PD-L1 1 to 49%, and 12% were more than 75 years of age, and 85% were smokers. And the median follow-up was 1 year. Next slide. So this is the results of IO chemo versus IO in this pooled analysis. It was statistically significant improvement in progression-free survival and overall survival, favoring IO chemo versus IO in the subset of PD-L1 1 to 49. You can see the overall survival nearly 21.4 months in the IO chemo arm compared to 14.5 months. Both the PFS and OS were better. However, the results presented are considered exploratory and hypothesis generating. This is the conclusion of the FDA-based pooled analysis. Okay, next slide. So if you look in the specific subsets of more than 75 years, in this subset, the IO chemo, even though the numbers were less, the IO chemo had a hazard ratio of 0.95, crossing unity. So if you're selecting frail patients or elderly patients, we should be careful in selecting the triplet IO chemo platinum. And then in never smokers also, even the numbers were small, it did cross unity. So in these two subsets, we should be careful using IO chemo combination. Next slide. So, well, to conclude, chemo IO may improve efficacy outcomes over IO alone in the subset of PD-L1 1 to 49%. Next slide. So the pros is that this is a very good comparison of IO chemo versus IO in the specific subset of 1 to 49, which is not usually addressed in majority of studies. It did include 8 randomized control trials with 2,000 patients and addressing good endpoints, that is overall survival and progression-free survival. Next slide. The cons is that it is a pooled analysis of results and not individual patient data analysis. And they have used the words like may, exploratory, and hypothesis generating. So these are the words they have used in conclusions. Next slide. So a meta-analysis of individual participant data would have had more power in terms of quality and reliability than aggregate data. Next slide. Okay, so my conclusions are that in the PD-L1 1 to 49%, IO mono is inferior to IO plus chemo. So we must opt for the IO chemo combination in the specific subset. And in PD-L1 more than 50%, IO monotherapy may be used, but however, even if the PD-L1 is more than 50%, we have some early progressors. So even in those patients, if the performance status is good and they're younger, we may use IO chemo if the disease burden is high. Thank you.
Thank you, Dr. Chandrakant. And it was a good analysis, and that's what they say to take over the concerns of early progression IO chemo in specifically this subset. And Checkmate 9LA was this kind of trial actually. But before Checkmate 9LA was a trial of Checkmate 227, and there is a 4-year update of Checkmate 227, and to take us through that is Dr. Sanyu D. Souza. He's a medical oncologist consultant at KMC Hospital, Mangalore. Dr. D. Souza.
Good morning, all. Thank you, Dr. Jatin.
Sir, I think network issue is slow from your side. You can switch off the video.
Can the organizers share the PPT, please?
Yes, sir.
Yeah. Yeah. So I'll be
Yes, sir. You can start.
this checkmate 227, that's nivolumab plus ipilimumab versus chemotherapy as first line treatment for advanced non-small cell lung cancer, the 4-year update. Next slide. So we know that nivo and ipilimumab have distinct but complementary mechanisms of actions that when combined can prolong the long-term survival in patients with melanoma, RCC and non-small cell lung cancer as seen in recent RCTs. Nivolumab restores the anti-tumor function of T cells, while ipilimumab induces de novo anti-tumor T cell responses, including an increase in the memory T cells. So this phase 3 checkmate 227 part 1 study previously showed that Nivo-EP significantly prolonged OS versus chemo in patients with advanced NSCLC, regardless of PD-L1 expression or histology. That was published in NEJM in 2019 by Hellman et al. And this current analysis reports the updated 4-year results from this particular trial. Next slide, please. This is the trial what I'll be presenting, which was published a couple of months back. Next slide, please. So if you see the study design, it was a randomized phase 3 trial, and the median uh, 50 follow-ups in recent trials. So the inclusion criteria were the patients with stage 4 or recurrent non-small cell lung cancer without known sensitizing EGFR alterations, no previous systemic treatment, and ECOG-PS of 0 and 1, no untreated CNS mets. 1,739 patients were randomized. There were 2 parts in this trial, that was part 1A and part 1B. Part 1A means those patients who had PD-L1 more than or equal to 1%. And part 1B included those patients with PD-L1 less than 1%. And if you see, the patients were randomized into 1:1:1 ratio into 3 arms. So the Nivo-EP arm, chemotherapy arm, and the nivolumab monotherapy arm in those with PD-L1 more than or equal to 1%. Nivo arm was combined with chemotherapy, and the dosage of nivolumab was 360 milligram every 3 weekly compared to 240 milligram every 2 weekly in the more than PD-L1 1% arm. So, and then the primary endpoints where there were dual primary endpoints, PFS in high TMB population, and another one was the overall survival in PD-L1 more than or equal to 1% population. Both of this was published in 2018 and 2019. And this particular study is the 4-year update. Next slide, please. Yeah, if you see the baseline characteristics, median age of around 64 years, smoking around 15% were non-smokers, around 30% were squamous cell histology. And if you see the PD-L1 status among in the subgroup with PD-L1 more than or equal to 1%, around 50% had PD-L1 more than 50%. But if you see in the combined, in the last column, in the combined PD-L1 population, in the Nivo-EP, among the patients who received Nivo-EP, around 30% had PD-L1 less than 1%, and around 70% had PD-L1 more than 1%. So next slide, please. Yeah, so this 4-year update gives us an updated OS and efficacy data with a minimum follow-up of 4 years. So we need to remember that patients were off immunotherapy for 2 years in this particular update, and it also gives us a comprehensive characterization of the safety profile of Nivo-EP, and also an analysis of efficacy in those who discontinued the Nivo-EP due to treatment-related adverse events. Next slide. Yeah, so the efficacy analysis in PD-L1 more than or equal to 1%. In Nivo-EP, 18% in the chemo arm, and the hazard ratio of 0.76. If you see the Nivo-EP, the OS curves of Nivo-EP versus nivolumab monotherapy separates at around 12 months. And then if you see the OS curves of Nivo-EP and chemotherapy, they separate over time. In spite of the fact that patients in the chemo arm later received nivolumab. This shows that dual immunotherapy is associated with the more durable efficacy. And if you see the median duration of response in the Nivo-EP arm was 23.2 months. Next slide, please. In the PDL1 less than 1%, the median 4-year OS of 24% versus hazard ratio of 0.64 and the median duration of response of 18 months in the NEO-EPM. Next slide, please. And if you see the efficacy outcomes for PDL1 in someone with more than or equal to 50%, the median 4-year OS was 37% in the NEO-EPM versus 20% in the chemo arm, and hazard ratio of 0.66, and the median duration of response was around 32 months in the NEO-EPM versus around 5.8 months in the chemo arm. Next slide, please. Yeah, so this is a quite interesting. If you see the percentage of patients in response at 4 years, in the NEO-EPM, whatever the PDL1, you see around 31 to 40% were in response at 4 years. If you see the PDL1 less than 1% subgroup, the NEO-EPM around 31% were in response. But if you see the NEO plus chemo arm, in those with PDL1 less than 1%, around 13% were only in response, suggesting that this dual immunotherapy works quite good, especially in those with PDL1 less than 1% too. Next slide, please. So if you see the safety, the treatment-related adverse events of any grade leading to discontinuation occurred in around 18% in the NEO-EPM. In the combined PDL1 population, if you consider only the PDL1 more than or equal to 1% population, around 16% had treatment-related adverse events leading to discontinuation. And the most common treatment-related adverse events leading to discontinuation in the NEO-EPM was pneumonia. Immune-mediated adverse event was rash, which occurred in around 90% of those patients treated in NEO-EPM. Next slide. Yeah. So if you see the efficacy of patients discontinuing due to treatment-related adverse events, the OS in the PDL1 more than or equal to 1% subgroup, the median OS was 30.6 months. If you see the 4-year survival was 44% in those who had discontinued the treatment due to adverse events versus 29%. And if you see the median duration of response after discontinuation was 52 months in the PDL1 more than or equal to 1% group, and which was and the median duration of response was 34.2 months in the combined PDL1 group. Next slide, please. So so this particular Checkmate 227 study showed that the NEO-EP continues to provide durable clinical benefit with no new safety signals when compared to a platinum-based chemotherapy, regardless of PDL1 expression or histology, as evidenced by the 4-year survival data. And discontinuation of nivolumab ipilimumab due to treatment-related adverse did not negatively affect the observed benefits, which is suggested that which was seen that approximately one half of the patients with ongoing response for more than 3 years therapy sparing option for first-line treatment of advanced non-small cell lung cancer.
Thank you, sir. So we can now move on to the next talk. Next talk is by Dr. Ravindra Nandhana. He is a consultant medical oncologist at Medicover, Visakhapatnam.
Good morning, everyone. Am I audible?
Yes, audible and visible. You can start.
Yeah. I'm going to present the article, Early Plasma Circulating Tumor DNA Changes Predict Response to First-Line Pembrolizumab-Based Therapy in NSCLC. This is the phase 3. This is the analysis from the phase 3 MYSTIC trial, which was published in the Journal for Immunotherapy of Cancer in this year. We all know pembrolizumab is approved as a monotherapy for first-line treatment for advanced NSCLC. If PDL1 is TPS is more than or equal to 50, and as a combination with platinum based doublet chemotherapy, regardless of the PD-L1 expression level. And the responses to either regimen occur in minority of cases, but currently available biomarkers like TPS are imperfect in their ability to predict the responses. And even tumor mutation burden have not been incorporated in routine clinical practice. And the timely identification of the patients who are not responding to the treatment is very critical for guiding the subsequent treatment decisions. And the rapid assessment of therapeutic efficacy prior to radiographic assessment could enable early modification of the treatment regimen, such as switching of the therapy or intensification of the existing treatment. And liquid biopsies are non-invasive method to detect the tumor-related mutations in the plasma. And plasma ctDNA currently used in the detecting targetable genomic alterations in EGFR all genes. And clearance of the ctDNA after treatment initiation associated with improved outcome in EGFR mutated lung cancer. And this study hypothesized that rapid changes in plasma ctDNA measured by NGS after of immunotherapy would enable early detection of response and resistance to immunotherapy in treatment-naive NSCLCs prior to radiologic assessment. Coming to the study, the advanced in NSCLC who received first-line treatment with pembrolizumab alone or with combination with platinum doublet at Dana-Farber Cancer Institute was enrolled in the study, and most of the samples were collected before each cycle. The samples were analyzed by NGS using tagged amplicon sequencing from 36 genes. And the objective response rate was determined using RECIST 1.1, and the PFS is defined as time from start of immunotherapy to date of progression, and OS is defined as time from the start of immunotherapy to death. And patients who were alive without disease progression were censored. And early change in ctDNA allelic fraction was correlated with radiographic responses with long-term clinical outcomes such as PFS and OS. Coming to the results of the study, in this table showing that clinicopathologic and genomic characteristics of the study, total 62 patients were enrolled, and median age of the population 61.5 year, and most of the 85.5% of population are current or former smoker, and 88.7% are having ECOG PS01. And tumor mutation status by tissue NGS is showing 21 patients, 35% of the patient having KRAS mutation, and most of the 38% of the population are not showing any kind of mutation. And the half of the population has received pembrolizumab alone, half of the population received pembrolizumab plus platinum doublet. And the more PD-L1 tumor proportion score is less than 1% in 23.2% population, and 1 to 49 in 17.8, and more than 50% in 58.9% population. Then out of 62 patients, ctDNA was detected in the 45 patients only at the baseline. And overall, 81 mutation was found with a median range of 1 to 4 each patient. Out of 45, 24 patients received pembrolizumab alone, and 21 patients received pembrolizumab plus chemotherapy. And the baseline ctDNA mutations were showing in this picture. It is showing that 43.2% of population having TP53, and KRAS mutation is showing that 23.4. And total 42 cases, the tissue NGS and baseline liquid biopsy is showing concordance. If more than one mutation was identified at the baseline, mutation with the highest allelic fraction was used to track the ctDNA levels. And this study shows early changes in plasma ctDNA level preceding radiographic response and correlating with clinical outcomes to immunotherapy. And this waterfall plot shows that percentage change in the correlation between the percentage change in the target lesion from the baseline and ctDNA increase or decrease. And the blue bars, red bars indicate ctDNA decrease, and the blue bars indicate ctDNA increase. Most of the red bars are showing that some kind of response, either complete or partial response in the target lesion from the baseline. Most of the blue bars showing that progressive disease. There is a linear correlation between the tumor response by RECIST criteria, like best objective response, and ctDNA change at the baseline, at the first follow. The median AF percentage change between the pre-treatment sample and first follow-up sample.
Dr. Ravindra, requesting you to conclude in 1 minute.
Yes, sir. The most of the, in this graph we show, most of the patients of complete response or partial response, showing that low median AF change, and most of the patients of PFS more than 6 months are showing that low median AF change. And the most of the patients with progressive disease are showing that significant change in the median AF change. The detailed kinetics of AF change were described in this graphs. Most of the patients of the partial response or complete response are showing that decrease in the ctDNA from the baseline. And the objective response rate is showing that which was higher, significantly higher in patients with decrease in plasma AF, which is 60.7%, and with compared with AF increase, which is 5.8%. And the ctDNA decrease preceding the radiologic response in 88% of the cases, while in 11% of the cases, ctDNA and radiographic response were concomitant. The PFS was significantly longer.
Can you come on the conclusion slide, please?
Yeah. The rapid decreases of ctDNA in advance of radiological and clinical assessment correlated with clinical benefit, and while increasing or newly detectable ctDNA was harbinger of progressive disease. This results suggest that potential role of longitudinal plasma ctDNA NGS analysis is a new efficacy metric to rapidly assess response or resistance to immunotherapy. Thank you, the organizers, for giving this opportunity.
Thanks, Ravindra. Thanks, Dr. Ravindra. Moving on to the next talk. The next talk is to be presented by none other than Dr. Vikas Talreja. He is a consultant at Regency Hospital, Kanpur.
Thank you, Dr. Akhil, and congratulations to all the organizers for an excellent conference. Apologies for not making it to the physical thing, but then the virtual is always the best mode. Today I will be discussing the Empower 150, the key subgroup analysis of the patients with EGFR mutations or the baseline liver metastasis. The most sought trial, probably I would say. We'll go back to the study design. Next slide, please. I suppose. Can you share the slides with? Perfect. So second slide, please. Yeah. So it was a stage 4 recurrent metastatic non-squamous non-small cell lung cancers, chemotherapy naive patients who were stratified based on their sex, PD-L1 expressions, and liver metastasis. The three groups were the ABCP arm, the atezolizumab, carbopecli, and bevacizumab. That was the arm B, followed by the atezolizumab maintenance. The arm A was the ACP arm, that is atezolizumab, carboplatin, paclitaxel without the BEV, and the third was without the atezolizumab with the BEV maintenance. And when it was presented in ESMO 3 years back, the PFS was significantly different. Next slide, with a 1 year cutoff of 37% progression-free survival in the ABCP group as compared to the BEV plus the CP group, with a median follow-up of around 15 months, which was significant at that time. In those with a T effector high subgroup, again the ABCP arm performed by a significant margin with hazard ratio of 0.5, 50% reduced risk of events in the ABCP arm. Next slide, please. And in those where the arm B and C were compared with the progression-free survival, you could see that the benchmark figure of 8.3 months without the progression in the ABCP arm. Now, in the AACR 2020, the final analysis was portrayed for and was presented by Tony S. Mock in that subgroup. So the final analysis was, next slide, please. Next. 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 Yeah. So the ABCP versus the BCP arm, the overall survival, there was a hazard ratio of 0.8, which means there was a 20% reduced risk of deaths when you give the with a median overall survival around 19 months as compared to 14 months. And the curves, look at the curves, they were outrightly separated throughout the initial crossover. And now also in the ACP arm, it was seen that the median was 19 months as compared to 14.7 months with a hazard ratio of again 0.84, meaning a 16% reduced risk of deaths. Now, the overall survival was consistently maintained and the graphs were quite remarkable. Next slide, please. The slide which was the focus 3 years back, as those with the baseline liver mets and those with the EGFR mutations, where we were struggling with the therapy. This continued to outshine, the hazard ratio being 0.6 with a clear-cut difference between these curves, with a median of 29.4 months in the ABCP arm as compared to the BCP arm where it was 18 months. And similarly, the overall survival in the as compared to the ACP arm, where you could see that the curves were exactly similar. So for those with the EGFR mutations, the ABCP is the thing to carry forward to. Simply atezolizumab with the Paclitaxel carbo combination isn't effective as compared to the BCP arm. So the quadruplet clearly outshined as compared to the triplet. And also in the liver metastasis, again, the quadruplet had a significant hazard ratio, nearly 33% reduced risk of deaths when you give the quadruplet as compared to the triplet. And if you look at the next slide, the PDL1 subgroup in the similar subsections, the ABCP arm again had a clear-cut advantage. And in the PDL1 positive, if you the atezolizumab, you see the ACP arm also had a similar advantage. The hazard ratio being 0.73 and 0.71, meaning a 27 and 29% reduced risk of deaths when you give the immuno BEV combinations. So that taken together, everybody of us know the ABCP regimen, the toxicities associated with it. Last 4 years has given us some experiences of handling these patients, and this trial was shown to be effective in the key subgroups of the liver metastasis and the EGFR sensitizing mutations, where the quadruplet clearly outshined the triplet. Opportunity, and back to the
thank you, sir. That was really helpful. So we'll be moving on to the next talk. Next talk is by Dr. Deepak Shukla. He's a consultant medical oncologist at Manipal, Jaipur. Your slides are visible, but sir, you are not audible.
Am I audible now?
Yes, yes, well audible and visible. You can start, sir, now.
I'll be speaking on the updated 5-year outcomes for the Keynote 24 trial. So the Keynote 24 trial was a phase 3 international randomized open label trial. It compared pembrolizumab at the standard dose of 200 milligram 3 weekly for up to 2 years and it compared it with the standard of care at that time, platinum-based chemotherapy for 4 to 6 cycles. And based on the histology, patients were given maintenance pemetrexed, and these patients were to have a PD-L1 expression of more than 50% without having a EGFR or an ALK alteration. So in this trial, close to 1600 patients were screened, and out of those 500 patients, that is close to 30%, were found to be PD-L1 positive for more than 50%. And from September 2014 to October 2015, close to 300 patients were on randomized 1:1 at 120 sites. These patients were 20% belonging to the squamous cell histology, and 80% were adenocarcinoma. There were 12 patients with brain metastasis in the pembro arm as compared to 8% in the chemotherapy arm. So we have some background results of this trial. At the previous reporting in the NEJM at the time of second interim analysis, at a median follow-up of 11 months, the trial showed that PFS was 10.3 months in the pembro arm as compared to 6 months in the chemotherapy arm, and it shows a hazard ratio of 0.50 that was significant. And at the second analysis published in 2019, at a follow-up of close to 25 months, the median overall survival was reported close to 30 months in pembro arm as compared to 14.2 months in the chemotherapy arm. Again, the hazard ratio was significant at 0.63. And the present updated analysis is at a 5-year follow-up of this trial. One must keep in mind that close to 66% of the patients crossed over from chemotherapy to pembrolizumab in the standard of care arm, and the Kaplan-Meier curve at the 5-year mark showed that the overall survival with the pembrolizumab arm was 31.9% as compared to 16.3%, with a median overall survival close to 26.3 months as compared to 13.4 months in the chemotherapy alone arm. The PFS was 7.7 months in the pembrolizumab arm as compared to 5.5 months. And at the 5-year analysis, close to 13% patients were progression-free in the pembrolizumab arm as compared to chemotherapy arm. The updated response rate reported in the paper published in 2021 in April showed that the response rate was 46% in pembrolizumab as compared to 31% in the chemotherapy arm. There were close to 5% CRs in the pembrolizumab arm as compared to chemotherapy, where it was none. And the duration of response was close to 2.5 years in the pembrolizumab arm as compared to 6.3 months in the chemotherapy arm. There was an exploratory analysis for the patients who completed the 35 cycles of pembrolizumab. Close to 25.8% patients completed their 2 years of treatment with pembrolizumab. And it is good to know that approximately 9 of these patients, that is 23% of these 39 patients, were previously treated from brain mets. Amongst these, 82% had some form of response based on RECIST criteria. And at the data cutoff at this 5-year time point, 81.4% of these patients were alive and 46% were progression free at this 5-year mark. There were the updated analysis regarding the safety, which was again a secondary endpoint, showed no new safety signals, and the serious treatment-related adverse events occurred in 22.7% patients in the pembro arm as compared to 20.7% in the chemotherapy arm. Any grade of immune-related adverse event was seen in 35% patients, the most common being hypothyroidism, followed by pneumonitis, followed by hyperthyroidism, skin toxicity, colitis. While the grade 3, 4, 5 adverse events were seen in close to 14% of the patients. Among these, skin was the most common grade 3, 4, 5 event, followed by pneumonitis, followed by colitis and hepatitis. In the pembro arm, there were 2 deaths, one due to pneumonitis and one due to an unknown cause. And In this trial, they have reported that the 12 patients were rechallenged with a second course of pembrolizumab after progressive disease by the investigator. Amongst these, 4 patients had an objective response rate. All of them were partial response. 6 had an stable disease as their best response. And at 5-year mark, 5 of these 12 were alive without a progressive disease and possibly may support pembrolizumab retreatment upon progressive disease. But seeing these impressive results in the Indian setting, we are left with few unanswered questions. We now have data for Keynote 1 trial, which was the initial trial done from May 2012 to July 2014, where a weight-based dosing of pembrolizumab at 2 milligram per kg was used. And subsequently, in April 2016, they have amended to a 200 milligram fixed dosing. The 5-year overall survival of this trial in the PDL1, more than 50%, showed a survival similar to what is reported in the Keynote 24 updated result, though the patients were only 27. The optimal duration of pembrolizumab, once they response, we do not know. In the trial, it was 2 years, but possibly a shorter duration could be sufficient. Even in PDL1, more than 50%, nearly 25% patient had a progressive disease as a best response, and we need better biomarkers for selecting patients with checkpoint inhibitors. So the key points from this Keynote 24 trial, that the approximately 25.8% of the patients have completed their planned 2 years of treatment. And out of these, 81.4% of the patients are alive at 5 years, and approximately 45% are progression free at 5 years, which is encouraging. And the median overall survival, as previously reported, is longer. And also the 5-year overall survival rates in the pembro arm is 32% as compared to 16.3% in the chemotherapy arm. Thank you.
Thank you, sir. So we'll move on to the next talk. Next talk is by Dr. Abhinav Zawar. He is medical oncologist at Aurangabad, and he is present in person here.
Good morning, everyone. I'll be presenting the Keynote 598 study, which was published in JCO by Dr. Michael Boyer. It is a study of pembrolizumab given with ipilimumab or placebo in participants with untreated metastatic NSCLC. So the background of the study was, as in the previous discussion we had, based on Keynote 24, pembro monotherapy is the standard of care in NACLC with TPS more than 50%. Despite this effectiveness of pembro monotherapy, still there are 50% of the patients who die within 2 years. Hence, we need to look out for more effective therapy. In fact, in this study, Keynote 24, after 2 approximately died. So looking at the favorable data on the first line single agent immunotherapy in PDL1 high patients, a question has arose as to whether have been continuously made to combine these drugs to leverage the different and potentially synergistic mechanism to improve the patient outcomes. So, and dual immunotherapy constitutes a standard of care in other advanced malignancies such as melanoma, RCC, and we have the result of CheckMate 227, which showed that first-line Nivo plus EP significantly prolongs the OS in comparison with chemotherapy in patients with NACLC with PDL1 more than 1%. The purpose of this study was to determine the efficacy of both pembro plus EP versus pembro with placebo. So the hypothesis was that OS and PFS is prolonged in patients who received IO-IO combination. So the inclusion criteria were histological endpoint. histologically confirmed diagnosis of stage 4 metastatic NSCLC, measurable disease as per iRECIST, ECOG PS 0 or 1, life expectancy of at least 3 months, and archival tissue sample or newly obtained core or excisional biopsy, not previously irradiated. Exclusion criteria were prior systemic chemotherapy or targeted or biological agents. They should not have EGFR, ALK or ROS rearrangements, previous radiotherapy, known untreated CNS meds, and active autoimmune disease, received steroids in the past 2 years. So this is a double-blind, placebo-controlled, randomized phase 3 study. So as we can see, the patients with untreated stage 4 NACLC, ECOG 01, no actionable mutation, PDL1 more than 50% assessed by IC22C3 Pharma DX study assay, and they were stratified based on stratified on PS, histology, and region. So the arm A, the intervention arm, received 200 milligram per every 3 weeks for at least 35 doses, plus EP 1 milligram every 6 weeks for at least 18 doses. The number were 284 in both the arms, and the primary endpoint was OS PFS as per RECIST, and the key endpoints, secondary endpoints, were overall response rate and the duration of response. So as we can see that the baseline characteristics were matched in both the groups. Almost the median age was 65 years, approximately 90% of them were smokers. 1/4 of the patients were squamous cell, and approximately 3/4 of our histology was non-squamous histology. So the planned interim analysis was at approximately 255 deaths, and approximately 12 months after the last participant was randomly assigned. Non-binding futility criteria at first interim analysis were difference in the restricted mean RMST, restricted mean survival time, between EP plus Pembro and placebo plus Pembro at less than -0.2 at the maximum observation time and 24 months of follow-up. So OS and PFS, there was no difference in endpoint. As we can clearly see, the median OS was 21.4 in the Pembro EP arm versus the Pembro placebo 21.9. The 12 months survival percentage was 63% versus 67, and the RMST difference was in both at 24 months and at maximum time. It was -0.5, just crossing the futility barrier. So we have here the median PFS also, the 8.2 months versus 8.4, hazard ratio of 1.06. So we can see this, both the curves are not separated exactly on top of each other. And so there was no difference in OS, neither PFS. And similarly in response rate, overall response rate was 45.4 months in both the 45.4% both the arms, and also the best response rate is also the similar. And now, in contrast to the overall response, PFS, everything, but in contrast, we have the safety wherein there is more toxicity with combination, all in treatment-related, immune-mediated. Any grade toxicities were 76% in the intervention arm versus 68%. If we take more than grade 3, there was 35% in the treatment-related in the intervention arm versus 19.6. Even if we take the immune-mediated, it was more in the intervention arm. And the adverse events leading to death were 2.5 in the treatment-related treatment-related to adverse events, 2.5 versus 0 in the Pembro plus placebo arm. So, and the most common side effects were seen was pruritus, rash, diarrhea. So coming to the discussion, OS and PFS outcomes observed with EP plus Pembro were comparable to those reported for EP plus Pembro in Checkmate 227, as we have seen. Likewise, the efficacy of Pembro monotherapy was similar across the Keynote 598 and Keynote 24. So it was neither Pembro did extraordinarily well, neither the EP Pembro combination did worse. It was both the drugs behaved similarly as we have seen in the previous study. So why did we have negative findings? So probably dual immunotherapy may not work in PDL1 expression more than 50% because the condition for immune checkpoints are already optimized. CTLA4 blockage will not add to the high level of pre-activated CD8 positive T cells in the immune microenvironment. Hence, additional CTLA4 blockage may not bring any clinical benefit as expected. Another bit of evidence to support the findings of Keynote 598 is the Checkmate 227, in which a group of patients with the very lowest TPS, less than 1%, had actually the highest and the most positive hazard. So basically, we tumor proportion score greater than 50%. There is no value in addition of EP to Pembro. It just adds side effect without any effectiveness. Pembro monotherapy remains the standard of care for this group of patients. Thank you for the organizing team to giving me this opportunity. Thank you.
Thanks, Abhinav. So we'll move on to the next talk. Next talk is by none other than Dr. Ashay Karpe, sir.
Good morning, everybody, and thank you for joining us on this wonderful academic feast. So definitely today is the day of immunotherapy, and I'll be discussing LBF 51 Empower Lung 3. It's semipilimab in combination with platinum doublet chemotherapy in the first-line treatment of advanced NSCLC, where we do not have any targetable mutation. This was presented in ESMO Congress 2021 in mini oral sessions, NSCLC metastatic. So this was a randomized two-part phase 3 study of first-line treatment patients. It has included both squamous as well as non-squamous stage 3-4 patients without any actionable mutations. It was a double-blind part 2 of the study. Patient enrolled irrespective of PD-L1 levels and compared with the clinical activity and safety of semipilimab and anti-PD-1 plus platinum-based chemo versus placebo plus chemo. Patients were randomized into 2:1 fashion, stratified by histology and PD-L1 expression to receive semipilimab 350 mg once every 3 weeks and placebo every 3 weeks for 108 weeks or until progression, plus up to 4 cycles of chemotherapy, followed by mandatory pemetrexed maintenance for non-squamous cell patients assigned to pemetrexed containing regimen. Primary endpoint was overall survival, and key secondary endpoints were progression-free survival and objective response rate as per blinded independent central review. This report is a part 2 results from the pre-specified second interim analysis. So overall, 466 patients were eligible. 312 patients were randomized to semipilimab plus chemo arm and 154 to the placebo plus chemo. Median age was 63. 57% had non-squamous NSCLC and 85.2% had stage 4 disease. The median OS was seen 21.9 months with semipilimab plus chemo versus 13 months was with placebo plus chemo with hazard ratio of 0.71. Semipilimab and chemo was associated with superior median PFS, 8.2 versus 5 months with hazard ratio of 0.56, higher overall response rate, 43.3 versus 22.7, and longer median duration of response, that is 15.6 versus 7.3 months. Definitely incidence of grade 3 side effects were more with semipilimab chemotherapy arm, 43.6% versus 31.4%. This is in brief all the results. Look at the complete response rates. It was 8 out of 312 in semipilimab arm, 2.6%, while 0 in placebo. Partial responses were 40% in semipilimab plus chemo versus 22.7 in placebo plus chemo. So duration of response by Kaplan-Meier estimated was 15.6 months in semipilimab chemo versus 7.3 months. So to conclude, in patients with advanced NSCLC, first-line semipilimab and chemo demonstrated clinically meaningful and statistically significant improvement in overall survival, the progression-free survival, overall response rate, and duration of response rate versus chemotherapy alone, with a safety profile consistent with semipilimab monotherapy and platinum-based chemotherapy. So definitely in patients where we do not have any targetable mutations, we definitely have maybe a newer option, so we can offer them. Thank you very much.
Thanks, Ashay sir. Now we move on to the next session. Next session is coordinated by my dear colleague, Dr. Hollis.
Thank you, Akhil. We'll be now concluding the session, the conference with a very important session, tips for immunotherapy, and no better person than the stalwart, the father of medical oncology in India. I invite Dr. Advani sir to be chairperson for this meet. Request Advani sir to introduce the first speaker, please. Advani sir, thank you for joining us today. I request you to please chair the session and introduce the first speaker for this session.
Yeah, good morning. I'm really very happy to chair this session, and we will have the session on the immunotherapy, particularly in the lung cancer. And I think Dr. D'Souza is going to present his paper.
I ask Dr. Anu, consultant medical oncologist, Jaipur, to start her session.
Good afternoon, all. My voice is audible?
Yeah, Anu, voice is audible. Your slides are visible.
Okay. First of all, thank you, organizing team, for giving me this opportunity in this wonderful event. My topic is effect of antibiotic therapy on outcome of immunotherapy. So this abstract was published in ESCO 2021, and this was analyzed by the Veteran Health Minister database. The hypothesis was that the dysregulation of the gut microbiota induced by antibiotic therapy may alter the anti-cancer immune response. So there were multiple small studies that show the detrimental effect on the immunotherapy. So this was the largest study in which they showed the detrimental effect of antibiotic therapy use in patients with non-small cell lung cancer, in which immunotherapy was used. So this study was conducted between 2010 to 2018. Two exposure of antibiotic was specified and separately analyzed. First was prior antibiotic, in which they defined as the antibiotic used within the 30 days prior to initiation of immunotherapy, and second was the concurrent antibiotic use, which was the use of antibiotic within the 60 days following the immunotherapy initiation. A landmark analysis of 2 months from immunotherapy start was applied. OS was measured from the start of immunotherapy using Cox proportional hazard multivariate analysis. Almost 3,600 patients were included, and most common immunotherapy used were nivolumab followed by pembrolizumab. The baseline characters were median age was 69. Most of the patients were male gender and of white race with comorbidity count more than 1. Half of them were adenocarcinoma with stage 4 disease. In prior antibiotic use, most common group of antibiotic use were beta-lactams, quinolones, and macrolides. So in the results, in patients in which the use of prior antibiotic had shorter OS than those without antibiotic use, in both multivariate analysis and the propensity matched cohort analysis, and the hazard ratio was 1.27. In concurrent antibiotic analysis, out of 3,200 patients, 30% patients received concurrent antibiotic use, and similarly, as we've seen in prior antibiotic use, they had shorter OS compared to in those without antibiotic. The ratio here also 1.3. In this table form, it is showing the same, the median OS. Even in matched result, the OS was shorter in both the prior and the concurrent antibiotic use. So in conclusion, it is clearly showing whether the use of prior antibiotic or concurrent antibiotic, there is definitely detrimental effect both on PFS and OS in patients with non-small cell lung cancer in which they use immunotherapy. These results were supported by a systemic review and meta-analysis published in the Journal of Thoracic Oncology done by Lise Lurin, and this they included 23 studies, and they shown the impact of antibiotics. In this forest plot, we can see the final result. The diamonds are on the right side, both in PFS and OS, and they show that the use of antibiotic can reduce the OS and PFS by more than 6 months. This is again supported by real world data from India done by Dr. Akhil Kapoor and the TMH team. This was retrospective audit of prospectively collected database between 2015 to 2018 at Tata Memorial Hospital, Mumbai. They included 155 patients, out of which 44 patients received antibiotic, and they shown median PFS was shorter, which was 1.7 months compared to 3.6 months in which antibiotics were not used. Similarly, median OS was 3.9 months compared to 9.2 months who did not receive antibiotics. Further, they divided the antibiotic exposure in two groups, less than 10 days of antibiotic and more than 10 days of antibiotic. And they shown that the median OS was shorter in patients who received less than 10 days compared to the 8.8 months in which they used more than 10 days of antibiotic. In this graphical representation on left side, they've shown the result based on less than 10 days of antibiotic therapy and more than 10 days of therapy, which is 2.8 months versus 8.8 months. They also analyzed the data based on the whether steroids were used with antibiotics or not. In patients where steroids were used, the median OS was shorter, which was 2.8 months compared to 5.4 months where steroids were not used along with antibiotic. So conclusion is that whenever we use immunotherapy in patients with non-small cell lung cancer, we should use the antibiotic judiciously, because in various studies, there is definitely a detrimental effect on immunotherapy results. Thank you.
Dr. Anu, thank you for sticking to your time. Excellent presentation. I now invite Dr. Davinder Paul, my senior, who is an assistant professor medical oncology at Dayanand Medical College and Hospital, Ludhiana.
Hello, good afternoon, everybody. Am I audible, please?
Yes, sir, audible. Your
Your
screen is not yet visible, sir.
So good afternoon, everybody. Thanks, organizer, for inviting me for this presentation. I'll be discussing about abstract presented in this ASCO, intestinal acromegalia mesothelia predicting overall survival in advanced non-small cell lung patients who are treated with anti-PD-1 antibodies. It's the results of the phase 2 study. Next. So the background of the study was that the gut microbiome, more specifically one of the most prevalent anaerobic bacteria, that is Akkermansia muciniphila, it has emerged as a potential hallmark for clinical benefit to the immune checkpoint inhibitors. So the goal of this study was to validate the prognostic significance of this bacteria in the advanced NSCLC patients who are amenable to treatment with immune checkpoint inhibitors. Next. So this multicentric prospective observation study was enrolled patients with advanced non-small cell lung patients who are amenable to single agent immune checkpoint inhibitors in first and second line. So the stool samples were collected at the study entry point. So the primary endpoint was this study was the investigator assessed objective response rate. So it was considered that a meaningful clinical difference would correlate to a 10% objective response rate increase in the Akkermansia positive group compared to the Akkermansia negative group. So at least 292 patients equally divided in each of this group would be required for a power of 80% and a two-sided alpha level of 5%. Next. So this study spanned over a period of 4 years from December 2015 to November 2019, and a total of 409 patients were screened, and out of these 311 patients were enrolled across the 12 academic centers in France and Canada. So the median age was 64 years, 32% were females, 77% had non-squamous histology, and the PD-L1 was more than equal to 1%, 70% of the patient, 70% of the total accessible samples. So this Akkermansia bacteria was detected in 51% patients and was absent in the 49% patients. And the baseline characteristics were well balanced between the two groups. Next. So when considering the Akkermansia positive versus Akkermansia negative groups, the primary endpoint, that is the objective response rate, was 27% in the Akkermansia positive versus 17% in the Akkermansia negative group, with a p-value of 0.04. So the rates of partial response, stable disease, and progressive disease were 62%, 50%, 46% in the Akkermansia positive group, as compared to 38%, 50%, and 54% in the Akkermansia negative group, again with a p-value of 0.04%. Moreover, 57% of patients were still alive after 12 months on the Akkermansia positive group versus 43% in the negative group. So the microbiome profiling further demonstrated that the Akkermansia positive group was associated with increased bacterial diversity and enrichment of other intestinal pathogens like Pneumococcus, Eubacterium, and others. Next. However, further considering the variations of relative abundance of akkermansia within the akkermansia positive group, they obtained a very large interval ranging from 0.002% up to 65%, with the 75th percentile falling at around 4.42%. The relative abundance of akkermansia within the 0 to 4.42% range in stools at diagnosis was associated with increased objective response rates, overall survival in the multivariate analysis, independent of the PD-L1 expression and the ECOG performance status. This subgroup was associated with more inflamed tumors with upregulation of other receptors like the VCAM and the CD3. Conversely, patients with the overexpression of akkermansia, that is, those patients who had an expression of akkermansia of more than 4.242%, they experienced a more progressive disease and a shorter overall survival. Antibiotic use, as said by the previous speaker, was associated with a shift in favor of gamma protobacteria and the further enrichment of akkermansia. That is, more antibiotic use was in those patients who had akkermansia of more than 4.42%, and this group was associated with a shorter overall survival. Next. So in conclusion, so this study validated the prognostic role of this bacteria, that is the akkermansia, in the patient with non-small cell CA lung patients. Stratification based on the akkermansia relative abundance represents a more accurate independent predictor than the binary modality. And this study provided the rationale to develop microbiome-based approach to gut study to study gut dysbiosis in routine clinical oncology care. Thank you.
Thank you, Davinder sir. Excellent talk. 2 back-to-back sessions on the role of antibiotics in immune checkpoint inhibitors. We now move on to the next topic. I request Dr. Gurvinder Singh, Assistant Professor, Medical Oncology, HBCH, Sangrur, for a talk on performance status and end-of-life care in NSCLC patients receiving ICA.
Good afternoon, everyone. Thank you, the organizing team, for giving me this opportunity. So I'll talk briefly about the retrospective review done regarding the performance status and end-of-life care among advanced non-small cell lung cancer patients who received immune checkpoint inhibitors. Next. So as we already know, as immune checkpoint inhibitors have changed the therapeutic landscape of advanced non-small cell lung cancer patients, but most of the phase 3 trials, they have taken patients with performance status of 0 or 1 into the entry. So clinical trial data suggesting the use of immune checkpoint inhibitors in a performance status of 2 or more is limited. Next, please. So non-randomized prospective studies of immune checkpoint inhibitors in patients of performance status 2, they have shown their safety, but they don't provide much insight into the survival. And there is also very limited real-world data regarding the same. So limited evidence in small cohorts of patients suggests that survival after treatment with immune checkpoint inhibitor among these patients is markedly worse as compared to patients who have a performance status of 0 or 1. Median survival was 13.4 months versus 4.2 months. Next. So all these in treatments, they have implications of end-of-life healthcare utilization, and among the patients, it is clear that who patients receive chemotherapy near end of life, they have higher risk of dying in intensive care unit, late referral to hospice care, and they have a more physical and psychological stress. Whether same apply to immune checkpoint inhibitors is not well described. Next. So this is a retrospective study done at Massachusetts General Cancer Hospital, Boston. They took a total retrospective patients of 237 and around 153 patients, they were PS of 0 or 1, and poor performance status patients were 2. Most of the patients were of the PS performance status of 2. And among patients who have a performance status of 2 or more who received immune checkpoint inhibitors, the median duration of immune checkpoint inhibitor therapy was shorter as compared to patients who have a performance status of 0 or 1. So median was 37 versus 119 days. Next. So regarding patient details, in patients who have a performance status of 0 or 1 or more than 2 or equal to 2, most of the patients received nivolumab in both the groups, and most of them received the immune checkpoint inhibitors as second line or later. Next. So overall survival and performance, progression-free survival, this clearly demonstrates that in a patient who have a poor performance status, their median survival and PFS was much shorter as compared to patients who have a performance status of 0 to 1. Next. So talking regarding the end of life outcomes, so initiation of immune checkpoint inhibitors within the last 30 days of life was much higher in performance status of patients impaired who were performance status of 2 or more, and hospitalization of these patients was also higher as compared to patients who have a good performance status. Next. So patients who received immune checkpoint inhibitors in the last 30 days of therapy, they were less likely to receive hospice care, less likely to be on the hospice care for more than 7 days, and more likely to be hospitalized in the last 30 days of their life, and more likely to die in a skilled nursing facility than patients who initiate immune checkpoint inhibitors more than 30 days from the death. Next. So this and other retrospective reviews, they demonstrate clearly that survival of patients receiving immune checkpoint inhibitors in impaired performance status is poor, and this collective evidence helps clarify that survival outcomes from pivotal phase 3 trials, they cannot be generalized to all the patients, and therefore such caution should be used in counseling the patient regarding immune checkpoint inhibitors in advanced non-small cell lung cancer patients who have impaired performance status. Next. So there is clearly a limitation, as this was a single center retrospective study. There can be bias of the practice patterns and you specific to that institution. And so there was also lack of socio-demographic diversity, which limits the generalizability of this study. And most of the patients in this study receive immune checkpoint inhibitor in the second line or later line of therapy. Next. So the trials are on the way, checking to assess the efficacy and safety of immune checkpoint inhibitors in patients with impaired performance status. So there is a need for the incorporation of adults with impaired performance status into randomized clinical trials, and the immune checkpoint inhibitors should be used judiciously in these patients, telling them the side effects and probable benefits. Next. Thank you. Thank you so much.
Thanks, Dr. Gurvinder, for an excellent presentation. I now invite Dr. Suresh Kumar, Consultant Medical Oncologist, Kaveri Hospitals, for a talk on immune-related adverse events and efficacy from the phase 3 trials, IMpower 130, 132, and 150.
Thank you, Dr. Hollis. At the outset, I would like to thank the organizers for giving me this opportunity. I'll talk about the pooled analysis of immune-related adverse events and efficacy from phase 3 trials, IMpower 130, 132, and 150. So background, immune-related adverse events are a common off-target immune activation seen in about 80% of patients who received immune checkpoint inhibitor therapy, and also it is seen about 95% of patients who receive combination immune checkpoint inhibitor therapy. Increasingly, evidence suggests that the occurrence of immune-related adverse events with immune checkpoint inhibitors may be predictive of improved outcomes in patients with cancer such as NSCLC. Atezolizumab has shown efficacy and tolerability in patients with lung cancer and is currently approved in both first line, second line, and beyond settings. So in this pooled analysis, we'll see 3 trials, IMpower 130 and 132. Both these trials evaluate the safety and efficacy of ATEZ in combination with chemotherapy in first line, and IMpower 150, which studied atezolizumab plus chemo plus Bev in the first line setting. So this is a pooled analysis of these 3 trials, IMpower 130, which studied atezolizumab plus nab-paclitaxel carbo versus chemotherapy alone, that is a nab-paclitaxel carbo in first line setting. The IMpower 132, which also studied atezolizumab plus a different chemotherapy backbone, which is PEM carbo or PEM-CIS, versus chemotherapy alone, which is PEM carbo, followed by maintenance chemotherapy or immunotherapy. And the IMpower 150, which also studied atezolizumab plus chemotherapy plus bevacizumab in first line setting, and this study also included EGFR and ALK treated patients. So this is a analysis plan of this pooled analysis. So in this, the 3 trials have been taken. Totally 2,503 patients were there. It is divided into 2 arms. One is that immunotherapy containing arm and the control arm. The immunotherapy containing arm is further divided into patients with immune-related adverse events and patients without immune-related adverse events, and which is further categorized into grade 1 to adverse events or 3 to 5 adverse events. So the demographic characteristics were similar in all the 4 arms, that is atezolizumab with or without adverse events, and control arm with or without immune-related adverse events. Majority of the characteristics are similar between all the arms. The only difference is the ethnicity. The Asians were relatively higher, which is about 18% in patients with immune-related adverse events in atezolizumab arm. This is a summary of immune-related adverse events. We can see that any grade immune-related adverse events are higher, seen about 48% of atezolizumab arm, versus it is seen only about 30 patients in control arm. Other side effects like rash, hepatitis, hypothyroidism, and pneumonitis are also commonly seen at a higher rate in patients who receive atezolizumab arm. The incidence of grade 3 to 5 adverse events like rash and hepatitis are relatively low, which is about 2%, 5%, and like that. Other rare immune-related adverse events include hyperthyroidism, colitis, infusion-related reactions, adrenal insufficiency, and pancreatitis. So if we see the survival according to the presence or absence of adverse events, we can see that patients on the atezolizumab arm who had immune-related adverse events have a significantly higher median survival, which was about 25.7 months, when compared with patients who did not have any immune-related adverse events, which is about 13 months. Similarly, in the control arm, we can see patients who had immune-related adverse events also had significantly higher survival, which is about 20 months versus 12.8 months. Based on landmark analysis at 1 month, 3 months, 6 months, and 12 months, we can see that in all these points, we can see patients who had immune-related adverse events with atezolizumab have a significant higher survival when compared with the other arms. The same thing. So atezolizumab arm, patients who had adverse events had significantly better survival at all the time frames, at 1 month, 3 months, 6 months, and 12 months, which was statistically significant. If you look at the overall response rate according to the adverse events in patients who are on atezolizumab arm, patients who had immune-related adverse events had a response rate of about 61% versus 37%. Similarly, in the control arm also, patients who had immune-related adverse events have a higher response rate of 42% versus 34%. Similarly, if we look at the various time points and characterizing the grading of adverse events into whether grade 1 or 2 or 3 or 5, or patients who did not have any adverse reactions, we can see patients who had grade 1, grade 2 adverse reactions, immune-related adverse reactions, have significantly better survival at all time frames. However, if you see patients who had grade 3 to 5 adverse reactions, they had a worse survival, possibly because of treatment discontinuation. Patients who had grade 3-5 reactions have poor survival. The same table depicting that at all the time frames, patients who had grade 1 to immune-related adverse events have a better survival, which was statistically significant, when compared with patients who had grade 3 to 5 who had worse survival. So this is the grade 3 to 5 immune-related adverse events in the landmark subgroups in the ATEEZ arm. The most common immune-related adverse events is hepatitis, which is seen about 52% of patients at 1 month, and also it's the most common adverse reaction at all the time frames. The other top 3 immune-related adverse reactions include rash, pneumonitis, and colitis. If we look at the treatment disposition, we can see patients who had grade 1 to immune-related adverse reactions. 75% of the patients were withdrawn from the treatment, and among that, 14% was because of adverse reactions.
Suresh, I request you to conclude in the next half a minute.
Yeah, I'm concluding, sir. So conclusions. So in these exploratory analysis of IMPOWER 130, 132, and 150 trials, patients who experienced immune-related adverse events show longer OAS than patients who did not experience these immune-related adverse events. The overall survival hazard ratio from the time-dependent Cox model in the ATEEZ arm was 0.69. And patients in the ATEEZ arm containing arm with grade 3-5 adverse reactions had a shorter OAS than patients who had grade 1 to immune-related adverse reactions. Similar to all the time frames, we can see patients who had immune-related adverse events had a significant longer survival. So data from these analysis suggests that there is an association between immune-related adverse events and efficacy in patients with NSCLC, and further support the use of atezolizumab combined with chemotherapy with or without bevacizumab in the first-line settings. Thank you.
Thank you, Dr. Suresh. We have the next session sponsored by BMS. I invite Dr. Vijay Patil, Professor Medical Oncology, Solid Tumor DMG, Tata Memorial Center for the talk.
Yeah, thank you. Thank you, BMS, for giving me this opportunity. No conflicts to declare for this talk. So what are we talking about today? We're talking about lung cancer, and we are talking about actually two studies, CheckMate 017 and 057. And it would be rare to talk about lung cancer and not talk about what we have achieved in last 1 decade. A decade back, if I would have said that we are going to discuss 5-year outcomes in patients who have been treated with second line or beyond, it would have been considered as like that I am crazy, and it would have been unimaginable. But here we are today. We are actually going to discuss the 5-year outcomes of CheckMate 017 and 057 studies. Now we all know that lung cancer is one of the commonest cancers which occurs in not only in India but also globally. We have two components called small cell and non-small cell, and non-small cell gets further divided into squamous and non-squamous. I won't go in details because this is a knowledgeable audience and knows already about this. Unfortunately, most of the lung cancer comes in stage 4, and when they come in stage 4, in spite of doing the best treatment, we land up that they require second line or beyond therapy. And so what we are talking today is a reality that it's very common that lung cancer patients would require second line or beyond therapy. And it's said that if 100 patients or patients are in stage 4, second line or beyond therapy is required in nearly 70% of the patients. And yes, second line of a decade back, the standard of care was docetaxel. And there was an interesting study, and I'll just quote the study. It was done by the Canadian Lung Cancer Medical Oncology Group. What it did is they passed on a survey, and the survey was passed to the Canadian medical oncologists who used to practice lung cancer, that if they had themselves had lung cancer, would they themselves give themselves second line or third line therapy? It was astonishing. Then less than 10% of, in fact it was 5% of Canadian medical oncologists were willing to give themselves the therapy because such were the dismissal results with the therapy. Docetaxel, though had an FDA approval, had actually given us dismal results. The median survival used to be less than 6 months, and hardly any patient used to go beyond second year. Now we all know that there are certain prognostic factors we look into metastatic non-small cell cancer, and what we actually look here at mainly at 2 or 3 points. One is a fitness for therapy, which actually a medical oncologist looks for whether the patient is fit for your therapy or not. And obviously, anyone wants a therapy which should be tolerable and should have less amount of side effects. The patient is seeing it from his point of view, where it should be having a larger duration of treatment and should have minimal impact on quality of life. Unfortunately, immunotherapies, nivolumab, pembrolizumab, both do follow this criteria. Now, when we talk about non-squamous cancer, we say that we give, if it's non-driver mutated, we give first line therapy. Then there are options for maintenance, and as I told you, nearly 60 to 70% of them will require therapy. And if you see here, one of the first choices is there is nivolumab and other immunotherapy agents which are to be given. The story remains same for squamous also. You give your first line therapy. This is again non-driver mutated squamous. There are options of maintenance, but when the patients progress, which most of the patients are eventually go, and around 60 to 70% of them will be fit for further therapy. Again, nivolumab stands as one of the first options which is there, along with other immunotherapy drugs. So let's talk about this outcome. And as I told you at the start of talk, it is unimaginable that we are talking about 5 years outcomes in a disease where stage 1 and stage 2, the 5 years outcomes are around 30 to 40%. In a disease where stage 3 lung cancer, when treated with chemoradiation, has median survival of 14 to 16 months, and 5-year outcomes again are difficult to get. Let's see about this. Understand these are stage 4 patients which are treated initially with first line therapy. They have progressed the second line or beyond. So which means even getting 2 years outcome would be considered a success, and we talk about 5-year outcomes. And this is the data. This is the data which shows you the 6-year OS survival rates. What the data is showing you is at 1 year, 42% of the patients are alive. By 2 years, 24% of the patients are alive. And by 5 years, 15% of the patients are alive. What I would interpret this data as, if your patients are alive at 2 years, there is nearly a 75% probability that the patient is going to go up till the 5th year. Obviously, these are elderly patients, and these patients would have comorbidities. People are going to die. You won't have any time 100% survivals. I would have been really interested if someone would have plotted a plot along with this of general population, how their survival decreases, and that would have given a very good idea how much we have overcome the impact of cancer in this populations. Let's revise what was the design. The design was about patients who had failed previous platinum-based therapy. In Checkmate 017, we had taken squamous cancer. In Checkmate 057, we had taken non-squamous. The question was basically simple, putting them across either nivolumab or docetaxel, and the primary endpoint was the gold standard, that was overall survival, and the other endpoints were PFS, response rate, and looking how this endpoints would do with respect to the PD-L1 expression. And what I'm is showing you here are the 5-year pooled results, both squamous and non-squamous taken together. Again, what you see here is that the curve with docetaxel starts separating at 6 months, and by 3 years there are less than 10% patients who are on docetaxel. But at the end of 5 years, even on nivolumab, it's 13%. Now, for some of you may say, okay, 13%, it's not a great number. But when you look at CA pancreas, stage 1, stage 2, which gets operated, the 5-year survival is the same. When you look at CA esophagus, with radical chemoradiation, the 5-year survival is actually less than this. Here we are again, and I'm making this point again, we are talking about stage 4 lung cancer who have progressed on first line of therapy, second line or beyond therapy, and we are talking about these results. So these results have to be seen in the context of what population it was there. If we divide these results with respect to PD-L1 expression, a higher PD-L1 is likely to have higher impact with nivolumab, and it does. You could see that there is nearly 6 times increase in the 5-year survival. It jumps from 3% to nearly 18%. So what you're going to tell your patient is that if your PD-L1 level is greater than 1%, out of 5, 1 patient is going to be alive by 5 years. And this has a high impact when the patient makes this choice, that out of 5, 1 patient is going to be alive till 5 years. What if the PD-L1 expression is less than 1%? It still benefits. Out of 10, 1 patient is going to go till 5 years. So we agree with this thing that we need better biomarkers, but it seems that higher the PD-L1, higher the benefit, but 1% also benefit. And so it should not stop you to being denying the patient of immunotherapy if the PD-L1 expression is less than 1% in second line or beyond settings. The interesting thing is, again, the initial slides were on pooled analysis. This is on squamous. Again, reiterating the same, that don't look at the medians. Look at what happens as 2 years, 3 years, 4 years. These patients who benefit have sustained benefit, which has been seen. Again, the benefit is shown in the slide in the adenocarcinoma patients. Again, hitting the same point that there is a sustainable benefit which you get in these patients. Does the benefit is limited to one cohort of patients who is overdriven? No. The benefit is seen across all cohorts, and you could see that in all the hazard ratios are in favor of nivolumab. Now, another interesting thing is that we have a habit in oncology of saying that if something is responding, let's not change that. The point is, if you have a response with docetaxel, the response with docetaxel is actually very less sustainable. You could see that the response with docetaxel was sustained for only less than 6 months in this study. If you have a response with nivolumab, this response is sustainable for 1.5 years on an average. And that's the result the patient. So if your patient is responding on therapy, the response is going to be there for a long time. And at end of 5 years, 32% of your patients, that is 1 among 3 patients who are responding, still will be having a sustained response. in this. What about the survival in these patients? So if your patient responds, and most of the response comes within the first to 2 cycles, this is great news. If your patient responds, the 5-year chances of surviving is greater than 50%. And this is important, that if the patient is responding to immunotherapy, the chances that they will do well is very good. And let's look at this landmark analysis. What is landmark analysis? Landmark analysis looks at patients who have been followed up till certain point of time, and taking this patient into consideration, we are predicting what would happen in the 3rd year, 5th year and beyond. If your patients have not progressed till the 2nd year, the chances that they won't be progressing by the 3rd year is 76%, by 5th year is 68%, and the chances that they will be alive at 5 years is around 60%. More interesting, if the patient has not progressed in the 3rd year, the chances that the patient won't progress in the 5th year is 90%. So if you have 10 patients who are not progressed till 3rd year, you can confidently tell that 9 out of 10 will not getting progressed by the 5th year. And the chances that they've been alive is as great as 70%. So obviously, more the duration of that they are progression free, the higher the chances that the survival will be higher. And this is an analysis which as clinicians we always like to do. Try to find out which are the patients who went beyond 5 years. And this is nice. And what it shows is performance status 0. The patients who had good performance status did better. And it also showed you that patients who had a PD-L1 expression of greater than 1% were the ones who did better. Unfortunately, there was no other marker, and that's the reason why at present you need to treat your patients with immunotherapy. And whenever you are looking at these curves, and this article was discussed as a part of our TMC Journal Watch also, what is not shown in the slides, and BMS has provided me the slides, and so I have not modified them, is that 1/3 of the patients on the docetaxel arm had received nivolumab, and this is what can be seen in this chart also, that after progression nivolumab was or any kind of immunotherapy was received. And there's a nice analysis done in the JCO paper, which was that if this had not been done, the separations would have been much higher. Now understand that these were trial patients. When you follow patients in a trial, you follow them very carefully. And in Indian studies, we have seen that even when you are carefully following these patients, out of 100, only 70% of the patients receive further therapy. I'm very sure this number in a real world practice would go down to 40 to 50%. And hence it's important that you give nivolumab at the first go when you get a chance, because when the patient progresses subsequently, you may not get a chance to administer immunotherapy in these patients. Now, again, you are giving immunotherapy for a long time. Does it increase the rate of side effects? And it's a good question to ask. You're giving it for 2 years, 3 years, 4 years. Does it increase the rate of side effects? And thankfully, the answer is no. The chances of the patient having side effects beyond 3 years, 4 years, 5 years is less, which means whatever dose adjustments which you require will be required in the initial part of the course, and subsequently the patient can be rest assured that he is unlikely to have any immunological adverse events which would come later. Though saying that, we should always monitor for immunological adverse events. There are good papers which say that immunological adverse events can come as late as 24 months. So this is my last slide. So nivolumab has led to be seeing something like 5-year survivals, which if I was been told at the start of my oncological career, I would have been just say that someone is just joking at me. So this is a reality today. And we also know that those patients who respond, the duration of response is good and it is sustainable. And patients who receive longer nivolumab, in them adverse events are less, and there's a better quality of life also seen in this patients. So this is one of your choices which you should consider if the patient has failed his initial line of therapy. That's all from me. Thank you.
Thank you, Vijay sir, for an excellent talk. We now move to the next session that is sponsored by MSD. I invite Dr. M.V. Chandrakant, again, a consultant medical oncologist, Narayana Super Specialty Hospital, Kolkata.
Thanks, Dr. Hollis, and thanks, organizers. And I would also thank Merck for the opportunity. I'll just check whether the slides are moving. If not, I'll ask the organizers. Okay, it's not moving. Okay, so can the organizers share from your end? I'll keep saying next. Well, in continuation to a brilliant talk by Dr. Vijay Patil, saying how important is survival in lung cancer, apt to the definition is redefining survival outcomes in non-small cell lung cancer, and I will be speaking on pembrolizumab. So we have two landmark practice-changing trials of chemo-IO combination, chemo-pembro combination, and that is Keynote 189, addressing the non-squamous non-small cell lung cancer, and the Keynote 407, that is squamous cell lung cancer. Next slide. Keep moving. No disclaimers. The slides are provided by Mark. Okay, so this we have discussed. Okay, next slide. Okay, so there's a high conversion to mortality in lung cancer. However, as we see, the 5-year survival mark has been reached. So it's becoming a more of chronic disease. Next slide. So this is the treatment options we have in lung cancer, and smoking cessation becomes one of the most important point. And we can even give systemic therapy to performance status 2 patients. And we have chemo, IO, TKI, all these are the options we have. Next slide. Next slide. So this is the ECOG 1594. It was published in 2002 that said that all platinum-based doublets are feasible. So the standard treatment is platinum-based doublet chemotherapy in 2002. Next slide. So you can see all the 4 platinum-based doublet equally do well. Keep moving. Next slide. So this is the BMJ 1995, where it said that the meta-analysis said that the absolute benefit of chemotherapy in non-small cell lung cancer was around 9 to 10%. So there is improvement in overall survival in terms of 10% if you give systemic therapy in the era of chemotherapy in 1995 and then around 2002. Next slide. So what we know about chemotherapy? So no survival benefit when we use triplet instead of doublets. The platinum-based doublet was the standard treatment, and then platinum-containing regimens are better than non-platinum combinations. Cisplatin is better than carboplatin, only in certain subgroups like stage 3B and in non-squamous variety. Otherwise, cisplatin and carboplatin are comparable, and whether 4 cycles of platinum or 6 cycles of platinum doesn't have any difference. Next slide. So this is the Scagliotti paper saying that for adeno it is PEM platinum and for squamous it is gem platinum. Next slide. Okay, keep moving. Next slide. So well, we all know that cancer is an immunosuppressive disease. It has its own ways of immune addition and altering the immune system in favor to it by expressing PD-L1 or by releasing chemicals that suppress immunity, increasing Tregs, and so on. Next slide. So this is important. We can understand that if we give IO alone versus IO chemo combination, so an immune cold tumor where we have more Tregs, less CD8 cells, and less APCs. If you use IO alone, this cold tumor can be converted to a hot tumor that is susceptible to immunotherapy by adding chemotherapy. So chemotherapy reduces Tregs, increases CD8 plus T cells, increases APCs, and increases antigen presentation, rendering it susceptible to IO-based therapy. So it increases PD-L1 sensitivity. That's what chemo-IO combination does. Next slide. So I will speak on 189. Next slide. So 189 is a phase 3 study. Before this, we had a phase 2 randomized trial, and now this is the phase 3 Keynote 189 study, 4-year follow-up. This is in non-squamous, non-small cell lung cancer. So no driver mutation, EGFR negative advanced lung cancer, irrespective of PD-L1, no prior treatment. All these were, and no active CNS mets. These were the inclusion criteria, and it was 2:1 randomization. 400, 200 each arm. It was randomization was pemetrexed platinum plus pembrolizumab, 4 cycles, or pemetrexed platinum plus placebo. And then if there was response to stable disease, it was pemetrexed maintenance in the standard arm or pembrolizumab plus pemetrexed maintenance. And it was continued for up to 2 years and so on. And there was around crossover was allowed in this particular study. And you can see the baseline characteristics. They were all well matched. You can see majority were smokers, and Asian population were less in this particular study. Both cis and carbo was used. Next slide. Okay, keep moving. Next slide. So you can see the study met its primary endpoint, and the 4-year overall survival is what we speak of, and the median overall survival was 22 months, nearing 2 years median overall survival. So as Dr. Vijay was saying, it is not the median we have to see the tail of the curve, and nearly 20-30% patients have long-term survival crossing 4-year mark. Next slide. So if you have a higher PD-L1, that is PD-L1 more than 50%, the responses are more magnified. These are highly positive results. You can see the positive results in both all the 3 subgroups, TPS more than 50, TPS 1 to 49, and TPS less than 1. In all of them, you have impressive hazard ratios of 0.5, 0.6, 0.7, and statistically significant improvement in overall survival, even in the TPS less than 1 patients. Next slide. So this is the progression-free survival. Again, if we use chemo-IO combination, the PFS is maintained, unlike IO monotherapy. Next slide. There's doubling of progression-free survival. Keep moving. So again, the PFS. So this is a wonderful forest plot looking into which subgroup benefited. You can see almost all the subgroup benefit, including PD-L1 less than, or the TPS less than 1%. So the magnitude of benefit was more if it is more than 50%, but all the subgroups have benefited with IO chemo combination. Next slide. So this is the PFS2. So the durability of IO responses and efficacy. You can see even the PFS2 is better in the IO chemo arm compared to the chemotherapy arm. Next slide. So the PFS2 is better irrespective of the amount of TPS expression, highly positive study. Next slide. The responses are of course better if you use chemo-IO combination. Again, if PD-L1 is more than 50, the responses are in terms of 60%. Next slide. Keep moving. So this is the 2-year OS rate. Those who survive 2 years, they have a nearly 80% chance that they will survive longer. So if you cross the 2-year mark, and you can see those who have long-term survival have nearly 75% response rates. So those who benefit are going to benefit, and they have very durable response, and chances of they crossing 4 years is phenomenal. Next slide. So there was an effective crossover, more than 50% crossover in the chemotherapy arm. In spite of crossover, the overall survival was maintained. So we are dealing with advanced lung cancer, and there is high chance that there are a significant number of patients, the chemo arm may not even go to IO arm. So therefore, it matters by exposing these patients to IO as early as possible in the frontline setting. Next slide. These are the grade 3 5 adverse events. We know that IRAE grade 3 are seen in just around 10 to 12% patients only. Next slide, next slide. So hypothyroidism, hyperthyroidism, rash are the ones that are more common in PD-1 inhibitors. Next slide. So pneumonitis is quite rare. Colitis is rare when you compare to CTLA-4 blockers. Keep moving. Next slide. So the takeaways are, with the 3 years of follow-up, Pembro plus pemetrexed platinum provide OS PFS benefit versus placebo. 3-year OS rate doubled with Pembro chemo. OS and PFS were improved irrespective of PD-L1 expression. Therefore, in non-squamous advanced NSCLC, pembrolizumab plus pemetrexed plus platinum should become the standard of care in all patients irrespective of PD-L1 expression. Next slide. So let's quickly go through the squamous data. Keynote 407. Keep moving. Next slide. Similar patient population, squamous has worse prognosis than non-squamous. You can see the improvement in squamous is not that great because they don't have driver mutations. Next slide. So this is how, again, 1:1 randomization. Here they have used Pacli or nab-pacli with carbo with pembrolizumab 4 cycles followed by Pembro maintenance versus placebo maintenance, and crossover was allowed even in this study. Next slide. So baseline characteristics, majority was smokers. That's what we can look into. Keep moving. Next slide. So you can see the overall survival. The study met its overall survival endpoint, 11 versus 17 months in the intent to treat population, hazard ratio 0.71. Next slide. So if the TPS was more than 1 or less than 1, you can see the hazard ratio was phenomenal. However, if it was less than 1, it crossed unity. Next slide. So this is the PFS data. Again, when we're using chemo IO, the PFS is better than the chemo monotherapy. Next slide. So the PFS, irrespective of PD-L1, more than 1 or less than 1, the PFS was better. However, it was more pronounced. The PD-L1 was more than 1%. Next slide. Again, you can see the better responses being there in the chemo IO combination arm. Okay, next slide. So this is the duration of response. So IO is the winner. When you look into duration of response, the durability of response is when compared to PFS. Next slide. Almost doubling of duration of response. PFS2, so there is spillover effect, or the efficacy of IO goes on even to the second line. That is PFS2. Next slide. Okay, irrespective of TPS, PFS2 is better. Next slide. This is when you adjust for crossover, you can look into the lower down. The orange one is if you adjust for crossover, the overall survival is much more pronounced. And even if there is crossover, the overall survival is different in the Indian treat population. Next slide. So adverse events, I think we discussed, it was in par with what we discussed before. Keep moving. Next slide. Next slide. Yeah. So the takeaways with that, with 3 years of follow-up, Pembro plus carboplatin and Pacli versus nab-pacli continued to provide overall survival and progression-free survival benefit versus placebo versus chemotherapy, versus placebo plus chemotherapy in patients with previously untreated metastatic squamous cell non-small cell lung cancer, irrespective of PD-L1 expression. And those who completed 2 years would live longer, and the chances of they having long-term survival is better. Therefore, taxane plus platinum plus pembrolizumab should become the standard of care in all patients with squamous cell carcinoma, irrespective of PD-L1 expression. Right? Last 2 slides. Okay. So this is specifically addressing a pooled individual patient data analysis of PD-L1 0 or less than 1%. Is there a benefit of chemo combination? Next slide. Okay, so they've combined all the 3 trials in specifically addressing the subset of TPS less than 1%. Next slide. So you can see if you look into TPS less than 1%, so if you pool the individual patient data analysis of all the 3 trials, there is statistically significant improvement in median overall survival, hazard ratio of 0.63, 0.5 to 0.79 being the confidence interval, Again, significant improvement in overall survival, even in the absence of PD-L1 expression. Next slide. The PFS also is better, even in low PD-L1. Next slide. So PFS2, PFS, and OS all are better, even if the TPS is less than 1%. Next slide. Overall responses are better, even if the PD-L1 less than 1%. You can see doubling nearly around 60% improvement in response rates if you add IU. Next slide. Okay, so I would conclude that in patients who have non-small cell lung cancer, whether it is squamous or whether it is non-squamous, chemo-IU, pembro plus platinum-based doublet combination should become standard of care in all patients, irrespective of the expression. Thank you, everyone, for patient listening.
Thank you, Dr. Chandrakant, for the detailed talk. We now move on to the most exciting session of the conference, that is the mega quiz. I request the organizers and Dr. Vikas Talreja, Consultant Medical Oncology, Regency, Kanpur, to take over, please.
Thank you again for the kind introduction. A very learned conference, I must say, and a very carefully selected agenda. I must congratulate the organizers for a brilliant piece of work that they've put together. And really, it feels enlightened to be at the end of this discussion. So I would be also feeling the same as all the people who have come and participated for the same. Now, best of luck for all those students who are waiting for the most awaiting part, exciting part of the conference, the mega quiz for it. And may I have the slide, please? Next. Yeah. So the first question is the grade 2 maculopapular rash management of the patients on immunotherapy includes all of the following therapy management, except you have to continue the immunotherapy. You have to take an urgent dermatological consultations, consider the biopsy, treat with the high potency topical steroids at the affected areas, or use prednisolone 0.5 milligram per kg per day. So you have to use all these management except immunotherapy is it 375 milligram per meter square every week, 375 milligram per meter square every 3 weeks, 1000 milligram flat dose every week, 1000 milligram flat dose every 2 weeks. What is grade 2 vision change with immunotherapy? Is it 20 by 200 vision? Is it 20 by 40 vision or the better one? The 20 by 40 vision or the worse one? Or 20 by 100 vision? So you have to interpret this checkmate 227 part 2 result, where the primary endpoint of the overall survival with Nivo plus chemo versus the chemo in patients with non-squamous non-small cell lung cancer histology was taken. And you could see the hazard ratio of 0.86, and you could see the separation of those curves with a p-value of 0.1859. So considering this curve, it looks like a positive trial as hazard ratio is 0.86, but control arm should have been different as compared to the chemo here. It is a negative trial as curves merge in the end. The positive trial as the improvement of OS is more than 3 months. The control arm had 15.8 while the Nivo plus chemo arm had the 18.8 months. And again, it's a negative trial because the pre-specified p-value was 0.044. Which of the following is the predictive as well as the prognostic molecular marker in various trials in immuno-oncology? It is a PDL1 expression. Is it a tumor mutation burden? Is it a T cell repertoire clonality change, or it's a T cell inflamed microenvironment? Which of the following is a pan ALK, ROS, and TRK inhibitor? So, which of these following molecules has an activity across all these three mutation types? Is it a reprotinib? Is it a lerotrectinib? Is it mericitinib? Or is it foritinib? Which of the following drugs work in the MET exon 14 skipping mutations but not in the MET amplification? Crizotinib, capmatinib, glesatinib, tepotinib. Now, the dose of the BRAF V6 inhibitor, encorafenib and binimetinib, is 300 milligram, which comes in the form of 75 milligram, 4 capsules to be taken once daily, with binimetinib being 30 milligram, which comes in 15 milligram, 2 tablets twice daily. Is it 450 milligram, 75 milligram, again 6 capsules once daily, or 45 milligram, 15 milligram, 3 tablets PD? 750 milligram, 75 milligram, 10 capsules once daily, 60 milligram, 15 milligram, 4 tablets PD? Or is it a 600 milligram, 75 milligram, 8 capsules OD, or 30 milligram, 15 milligram, 2 tablets PD? Now, the TTMB cut point for the clinical utility for the overall survival for all the keynote trials. It is a tumor mutation burden, which I'm talking about. So what is the cut point for the tumor mutation burden across all keynote, that is the pembrolizumab trials, which we see? Is it the 13 mutation per megabase pair by the Foundation One platform? Or is it the 10 mutations per megabase pair by the Foundation One platform again? Is it 175 mutations for the whole exome by the whole exome sequencing platform? Or is it the 18 mutations per the whole exome by the whole exome sequencing platform? Now, e-cigarette or the vaping products associated lung injury is caused by the vaping tetrahydrocannabinol, nicotine. Is it the vitamin E, or is the chewing content in that? Now, which of the following drugs is not used in the steroid refractory myo or pericarditis due to immunotherapies? ATG, azathioprine, mycophenolate, intravenous immunoglobulin. You have to mention the drug that is being crossed here. That is, it is a 1-methyl D-tryptophan inhibitor. Is it the ipacodostat? Is it the ulixertinib? Is it the venetoclax? Is it the midostaurin? IFCT 302, which was a randomized trial post-surgery on follow-up, demonstrated that there is no difference between doing an X-ray or CT on follow-up in survival outcomes. Now, if you do CT scan, you get an earlier diagnosis of the recurrences and hence the survival benefit. If you do an earlier diagnosis of the recurrences and the secondary primers and primary cancers, you could diagnose them and hence you can get an overall survival benefit. Only the early diagnosis of the secondary primary cancers and hence the survival benefit. Across the trials, which of the following drug has the highest 1-year overall survival rates in the third line and beyond small cell lung cancer? Is it the nivolumab, pembrolizumab, enlotinib, rovalputuzumab tesirine? Which of the following abstracts presented in ASCO had a positive results this year? So it was a high dose twice daily thoracic radiotherapy in limited stage small cell lung cancer. Is it the durvalumab and the tremelimumab with chemotherapy combination as the first line extensive disease small cell lung cancer? The dinuximab anti-GD21 plus irinotecan in second line extensive stage small cell lung cancer, or is it the Keynote 64 pembrolizumab trial in the first line extensive disease small cell lung cancer? Thank you for your participation. I hope everybody has got every answers right. Any problems, you can mail me anytime. And thank you for the opportunity, and back to the organizers for a wonderful conference.
Yeah, thank you, Vikas. Nice to see you, first of all. And I mean, actually, he's a quiz master. Dr. Akhil. So we have many quiz masters, basically having this at all these meetings. So now this is the last thing of this conference, vote of thanks. And definitely no conference is complete without the participation of all the faculties and delegates. So at the outset, I would like to thank all the faculty members which has actually made this conference successful, and all the delegates who were present physically or on the were present virtually. So who actually are most important thing in this particular conference. The scientific partners were Roche, AstraZeneca, MSD, Novartis, Eli Lilly, Pfizer, Dr. Reddy's, BMS, Glenmark, Abbott, Emcure, Zydus, Intas Oncology, Phobos Care, Alchem, MedGenome, Cipla, Cadila, Guardant, Premas Life Sciences, Sun Oncology, BD, and Nelvin Life Sciences. So I thanks all scientific partners without whom this conference are not possible. Thank you for your unconditional support. Next, I would like to thank Dr. Kumar Prabhashar, who is basically all these meetings are the brainchild of Dr. Kumar Prabhashar and definitely his dreams. Thank you, Dr. Vanita Madam. Thank you, Dr. Vijay Patil. And thank you all organizing team members, basically, who are most important. And lastly, not but the least, especially the Team Horizon, basically, which is, I think, always plays very pivotal role in conducting these conferences, arranging all logistics basically towards these conferences, and coordinating between all faculty members as delegates. And lastly, but not but the least, for the excellent arrangement made by Hotel Sahara Star and team. So with this, I thank you again all. If anyone I would miss, again, sincere apologies for the same. And I think we'll conclude these sessions. Thank you very much. So following this, we have actually TMH alumni meet, which people can arrange either physically or virtually. So the Zoom link already has been sent for the same. हाँ सर यहाँ पे आ जाओ.